the chair of the UPPJH Department of Orthopedics, Dr. Juanito Javier, for some opening remarks.
Good afternoon, everybody, and welcome to this afternoon celebration of the World Osteoporosis Day. First of all, I'd like to congratulate and say thank you very much for the champions in the cause in our fight against osteoporosis and fragility fractures. Here in the Philippines, I'm proud to say that PGH is a leading light in pushing forward our agenda to minimize and lessen the morbidity of fragility fractures. This afternoon, I look at the program and we are to be gifted with very interesting keynote talks about osteoporosis. And I am sure we all would learn a lot from this. And I hope that in the future, it will always be a World Osteoporosis Day, so that we'll be reminded that this is a very, very pathology problem that we all should be able to solve, because there are already ways of treating them and minimizing the potential morbidity of this osteoporosis. So with that, I would like to say good afternoon to everybody, and let's begin the anniversary, the celebration of the World Osteoporosis Day. Thank you.
Thank you, Sir Enning, Dr. Javier. Okay. We would like to hear for some inspirational messages. First, from Dr. Rachel Ann de la Vega, the director of the UPNIH Institute of Aging. Because big subset of patients that will be benefited from this activity are, of course, the senior citizens or the elderly. So may we hear from Dr. Rachel.
Greetings from the Institute on Aging, NIH UP Manila, on the 6th World Osteoporosis Day. Congratulations to the UP Manila PGH Department of Orthopedics, especially its ortho-geriatric team and fracture liaison service, ably led by Dr. Irene Cabu and Chairman Dr. Juanito Javier. The geriatric clinic of the Department of Medicine UP PGH has been actively participating in the multidisciplinary management of persons at risk for and suffering from the consequences of osteoporosis. Older people aged 70 years and older, those who manifest a need for assistance in their activities of daily living, are screened for osteoporosis. Those who come with a history of fragility fractures are managed through an evaluation of their fall risks, frailty status, and nutrition status. Post-operative follow-up is also provided with the cooperation of the Departments of Orthopedics and Rehabilitation. The UP-WISE and Fit for Frail are two major recent projects of the IA-NIH that help us understand how we grow old in the Philippines through the comprehensive geriatric assessment, quality of life, nutrition, and frailty evaluation. These researches help us identify those at risk for falling, fracture, and frailty. May you have a successful sharing of new knowledge that will prevent osteoporosis and its complications. Happy 6th World Osteoporosis Day.
Thank you, Ma'am Shelley, and for the support that the geriatric clinic has been providing for the fracture liaison service, for our fracture liaison service and orthogeriatric clinic. So next, we'd like to hear from the UP Manila Chancellor, Professor Carmencita Padilla, for her messages.
Good afternoon. It is a pleasure to welcome you to the commemoration of the World Osteoporosis Day through this webinar hosted by the Department of Orthopedics, Multidisciplinary Ortho-Geriatric Fraction Liaison Service Team, and the Fragility Fracture Network Philippines. We are heartened by the sustained focus on this problem that affects the elderly the most. Fragility fracture is a very big problem, and only through unified and concerted efforts are we able to make a difference. The past few years have witnessed these joint efforts bore much fruit and intensify service to this sector. the expansion of the multi-center orthogeriatrics fraction liaison or FLS project that is a first in the country is a strategic initiative that is striving to be a model of ideal elderly fragility fracture care in the Philippines. For years now, since it started in 2018, the project has been improving the pathway of care for elderly patients with hip fractures, considered worldwide as an epidemiologic emergency. It continues to serve senior citizens despite the challenges brought about by the pandemic. It is a source of pride and institutional excellence and relevance that the FLS project has been getting regional and global recognition from the Asia-Pacific Fragility Fracture Alliance and the Fragility Fracture Network Global. But its continued partnership with the National Institutes of Health's Institute of Aging and the Department of Science and Technology to expand its services to other hospitals. The project affirms the role of research in enriching the lives of patients. The presentation of researches and sharing of experiences and best practices by recognized experts and authorities in this field are valuable in exploring and responding to the challenges of managing multi-fracture fragility among the Filipino elderly. It has become very clear that research is foundational for an advocacy to prosper. Hence, this endeavor will go a long way in ensuring success in this field of osteoporosis. I'm also glad to note that UP Manila, as the nation's health sciences center, continues to address not only this pervading great challenge that is COVID-19, but also ensures the least collateral damage to other health concerns. We are all being called upon to make sure that other medical conditions like fragility fractures are being managed well. Sharing this goal with other committed institutions and organizations for a more effective and efficient management of fragility fractures in older adults and the elderly becomes more encouraging, meaningful, and fulfilling. As the leading health university, UP Manila fully supports these kinds of endeavors. Let us therefore unite our hearts and minds towards ensuring that our population of elderlies will be healthy and sturdy. Maraming salamat po and mabuhay.
So thank you, Chancellor Padilla, for those very inspirational messages. As you all know, Chancellor has been very supportive of the multidisciplinary orthogeriatric and FLS team, no, in UP Manila since it started in 2017. Actually, this is in line with this World Osteoporosis Day celebration. We are also celebrating the 5th year anniversary of the UP Manila Orthogeriatric and Fracture Liaison Service. It started in 2017. So we would like to recognize later the participation of the different departments in making this endeavor possible, because this is a real teamwork, and this is what we want to impart to the other hospitals in order to carry out this advocacy. Okay. So before we start the presentations, I would just like to thank our industry supporters, Zuwilig Amgen and Fonterra brand, the makers of Anlin milk, for partnering with us, in celebrating this World Osteoporosis Day celebration activity of UPPGH. Okay, so before we start and before I introduce our first speaker, I would just like to give a background, of our journey, since 2017. So allow me to share some slides. Okay. Okay. So are you seeing my slides? Sorry guys, as much as I want to be there face to face, for due to some health reasons, I'm unable to be present. They're at the conference room. That's why I'm facilitating this online, but via online. Okay, so just please remind me if there are some glitches, in the presentation. So the UPPGH Orthogeriatric Fracture Liaison Service started in 2017. So it's 5 years and running. Okay, so there are many ups and downs. Now we started by just conducting symposium regarding multidisciplinary management of fragility fractures. But in 2017, after we were enlightened by what is now known as Global Orthogeriatric Care by the Fragility Fracture Network, we were able to at least bring the teachings of orthogeriatrics and FLS to the Philippine General Hospital. And as you can see at the picture above, this was supported by the different departments, namely the Department of Internal Medicine, Anesthesiology, Rehab Medicine, and Family and Community Medicine. And of course, this could have not been possible without the support of the PGH Director, Dr. Gap Legaspi, and Chancellor Padilla. So through the first 2 years, we were able to conduct face-to-face workshops, promoting fracture liaison service in orthogeriatrics in the Philippines involving different hospitals, and we were able to invite some leading champions around the region. Okay, we were also able to establish the Fragility Fracture Network Philippines with a core group of members coming from our multidisciplinary service in UP Manila. Okay. And with the support of the PGH administration, in 2019, we were able to introduce and implement the clinical pathway for geriatric patients with acute hip fractures, as approved by the PGH hospital operations, and the director. This is based on the major evidences coming from the first world country, and this was signed by some of the champions coming from the 4 different departments, as I've mentioned earlier. So we've been carrying out this pathway of care with the multidisciplinary team since 2017, and we were also able to enroll our FLS program to capture the fracture map of the International Osteoporosis Foundation. And true enough, after just a few months of implementing this pathway of care, embracing orthogeriatric care, as well as instituting the fracture liaison service in the outpatient setting, we were able to bring down the waiting time for surgery for elderly patients with hip fractures from about 14 days to about 5 days. And we were also able to decrease the average hospitalization stay of the patients from 21 days to 12 days. And we were able to get more follow-up, more compliance to anti-osteoporosis medications, and we were able to also prevent secondary fractures. Okay, 2020, before the pandemic, before we had the pandemic, we were awarded the bronze, okay, the bronze badge from the IOF. Okay, and right now there are 6 FLS programs in the Philippines. Included is the Philippine Orthopedic Center, which has a badge of silver, and 4 other hospitals, private hospitals, both in the Luzon, the Visayas, and Mindanao area. However, because of the pandemic, I think all the programs stopped, and it was really difficult to carry out this project. But through these talent challenges, we were still able to conduct researches, multi-center researches, in order to keep the advocacy alive through these challenges. So with the support of different public and private hospitals, we were able to conduct some multi-center projects in order to map out the care that we give to these patients during the pandemic, right? And as Chancellor Padilla mentioned, we are blessed to have a pilot hip fracture registry project in the Philippines, which was launched last May. This includes 14 hospitals, public hospitals under the Department of Health. Okay, and this is funded by the Department of Science and Technology. The main goal is to create centers of excellence for multidisciplinary orthogeriatric care in the Philippines, and also to expand FLS programs in the country. So the goal is, after this 2-year project, we can enroll more institutions in the Capture the Fracture program, and we can have more orthogeriatric centers, where our elderly patients can go and come. So even with those achievements that I've mentioned, more work has to be done. As you can see, we have very little data in the Philippines compared to the other neighboring countries as regards to the numbers, on how we track hip fractures or osteoporotic fractures in the Philippines. Okay, so most of the time when we see conferences abroad, for the Philippines is always not applicable, or we were not included in the study. Also, this is very alarming, especially with the pandemic and the destruction effect brought about by the pandemic, especially in the rural areas. I think 30 to 40% of elderly patients having hip fractures are still being treated conservatively. They still go to the manghihilot, the traditional bone setters, and these patients are not given the proper care that they deserve. And of course, I just received this text message, from one of the concerned doctors, alarming me, that we are still far from really achieving our goal to make osteoporosis and fragility fracture management really a mainstream of here in the Philippines, like this. Good morning, Doc. Unfortunately, hindi kami nagko-cover ng osteoporosis as diagnosis kasi po this is still a part of a normal aging process, unlike cancer patients. So I think this activity will help us further understand why osteoporosis, and the management of fragility fractures now should be considered as an important and real concern moving forward, because it really affects the lives of our patients, our mothers, our lola, and 20 years from now, we will be senior citizens. It's really important to prepare as we move forward. Okay, so I'll stop my screen share. So with this, I would like to introduce our first speaker. Our first speaker is actually very instrumental in helping us to write the protocol for our pilot hip fracture registry project here in the Philippines. She is a member of the Fragility Fracture Network Hip Fracture Registry Special Interest Group. She is also part of the steering group of the FFN's Global Orthogeriatric Survey Project. Okay. She is the immediate past registry manager of the Australia-New Zealand Hip Fracture Registry, and she's a current consumer reporting manager for the ANZ Hip Fracture Registry. So it's my pleasure to introduce Miss Elizabeth Armstrong. I'm very excited to hear this talk.
Thank you, Erwin, and the organising committee for your kind invitation to speak today at the 6th Annual World Osteoporosis Day celebration of the University of the Philippines, Manila, Department of Orthopaedics. I'm Elizabeth Armstrong, the immediate past manager of the Australian Hip Fracture Registry, and currently the consumer reporting manager for the registry, as well as a PhD candidate at the University of New South Wales here in Sydney. Before the registry, I had a brief time in health policy and research roles, which combined with my background as a physiotherapist, gave me an understanding of the complexity of the health system. As a clinician, working in all of these roles has been an eye-opener into what goes on above and around each of us, working with patients when they arrive at hospital with an injury that needs treating. Today, I'm going to share with you the findings of this paper published earlier this year. It was an exploratory qualitative research project undertaken as part of my PhD. I will provide some background on why we did it, what we did, and some of the implications and reflections of its findings for how hip fracture care is provided. I would like to take this opportunity to acknowledge the contribution of my co-authors, as well as the 35 participants who contributed their perspectives and insights on hip fracture care. These are my disclosures. I'm employed by an independent medical research institute and am the recipient of a research scholarship. I receive no other financial support. Perhaps we are all aware of these statistics on the system-wide impact of falls and fractures in older people. What is really important, I think, are the last 2 points, specific to the functional outcomes of older people after a hip fracture. Fewer than 1/3 of older people will regain their pre-fracture mobility, and fewer than 1 in 5 will experience no ongoing restriction to usual activities of daily living. Not only is this a bad outcome for the older person with the hip fracture in terms of functional recovery, but for the family, there can be significant implications of this poor recovery for their roles. The ongoing disability after a broken hip means someone may need to be available for caring responsibilities, at least in the short term, and this may create additional expenses or impact the family member's ability to earn income. Hip fracture has wide variation in incidence, and in all settings, women are more likely to have a fracture than men. It is considered a surgical condition where the best outcomes are achieved by surgery. Non-surgical management leads to reduced function and loss of independence more so than operating. In high-income countries, more than 90% of older people with a hip fracture are surgically managed, compared with fewer than 50% in developing countries. The reasons for a focus on hip fracture of all the fragility fractures is because they are the most significant for the patient in terms of pain, loss of function, recovery time, and need for surgery to get the best outcome. For those reasons, they are the most costly for the patient, for providers, and for the health system. They are the easiest of all fragility fractures to measure because they can be consistently diagnosed and are often presented to hospital. And finally, they are a marker of the quality of trauma care. If clinicians, providers, and health systems are able to provide good quality care to this group of patients, then it is likely they will have systems in place to provide good quality care to trauma patients more generally. Globally, initiatives have consistently taken the same approach. They use existing research and clinical guidelines to inform the development of agreed measures and then collect and use data to see what impact any changes to care may have had. This combination of using evidence, measures, and data have been shown to be effective for health systems and individual provider organisations. This benefit has been shown across settings where co-managed surgeon-physician care has improved hospital and patient outcomes, as has multidisciplinary teams providing recommended care across the whole hip fracture pathway. Existing evidence suggests patients have variable access to surgical care and access to specific clinical specialties, such as geriatricians. Tian in 2016 and Rath et al. In 2017 documented an uncharted burden of people with hip fracture. No presentation to hospital or delayed presentation leading to no admission. In this study, we were looking at barriers and enablers of the provision of hip fracture care across different countries. And we wanted to extend the work that had already been done in a variety of settings. So we used the British Orthopaedic Association and British Geriatric Society Blue Book for the care of patients with fragility fracture to guide the data collection. These are the 6 recommendations, and we use the Blue Book because its recommendations are widely accepted and achievement of its 6 quality standards has been shown to improve outcomes for patients and providers. More importantly, the Blue Book's recommendations have already been successfully used in developing countries. We were interested in what currently happens, what are the problems faced by clinicians and administrators, are there already processes in place to identify problems? We explored the processes, structures, resources, clinical relationships, and decision-making of current hip fracture care in different countries. We used clinical and research networks to invite clinicians and administrators working in hospitals providing surgical care to patients with hip fracture. We wanted to maximise the variety of participant expertise and experience. with the aim of achieving a diversity and richness of views. We started data collection in August 2019, hoping to finish by early 2020. We were delayed by the pandemic, completing the data collection, and also the subsequent analysis was impacted. We used the Blue Book to guide the thematic analysis. The 35 participants were from different countries and different settings within each country, with different patient volume and hospital provider type. Hospitals were a mixture of publicly funded, charity funded, and privately operated facilities. Interview time varied, as did mode of interview. We identified 5 primary themes from the qualitative data collected, and these identified a variety of factors at the level of the patient, or the organisation, or the health system. This differentiation is important from a quality improvement perspective, as it helps to highlight what level of the health system would be the target of any improvement initiatives. It also helps to prioritise quality improvement approaches from easy to hard, because achieving early wins is a motivating force. First aim of the project was to identify barriers and enablers. Taking a strengths-based approach and focusing on the identified enablers, participants identified a variety of ways to address barriers to the use of the Blue Book standards. Alternative financing arrangements in the absence of universal health insurance, clinical staff working closely with and incorporating family members into the multidisciplinary team, the use of protocols or checklists to facilitate early admission to hospital, examples of delegated and clearly defined responsibility for the prevention of pressure injuries, and an openness to using audit to identify opportunities for improvement. What was also evident was that the enablers were targeted at organisational factors and clinician-patient factors, as well as the attitudes and beliefs of participants. We found that despite significant barriers to the use of the Blue Book standards, there were many examples provided by participants about how they were able to provide good quality hip fracture care utilising creative solutions. This suggests that using the Blue Book, it's applicable as a guide to reviewing hip fracture care in diverse settings. However, the solutions developed and implemented need to be closely aligned with the local context. Looking for ways to reduce the financial barrier for patients may be a place to start. Multidisciplinary teams agreeing to a checklist of essential investigations for older people with hip fracture may limit unnecessary testing, thus expediting admission and possibly surgery, as well as reducing costs to the patient and family. Local solutions will always be the most effective. In summary, we found that currently there is a mismatch between the clinical needs of older people with a hip fracture and the health system's ability to meet these needs within a patient's capacity to pay. Locally developed and applied solutions that target individual and organisational factors are evident, although multi-level solutions are required in some cases to ensure the needs of the population are served. In the absence of system-level approaches, individual clinicians and the organisations they work for can systematically collect and use data to identify gaps in hip fracture care to inform locally relevant improvement initiatives. Before I finish today, there are a few takeaway points I would like to leave with you. These are more of a reflection based not only on this qualitative study, but also my work with the Hip Fracture Registry over the past 7 to 8 years. Data is powerful, therefore collect it and share it with others. Make it specific to the audience. Chatting with one of the clinical leads at a New Zealand hospital just last week, she told me how she was able to achieve change by doing a medical record audit on patients receiving nerve blocks in the emergency department and presenting the data to the emergency department staff. They were surprised only 3% of their patients were receiving a nerve block because their perception was that they were doing great. Takeaway 2, Participants in the qualitative study told the researchers about the many causes of delay between injury and getting to hospital. They can be broken down into 3 types of delay. And what is important to realise is that some of these delays are outside the ability of clinicians or even the hospitals to change. Lack of ambulance services is possibly one of those. However, data can tell any of us that there may be other causes of delay that we can influence. For example, using informal networks to promote providers of good quality hip fracture care. Word of mouth can mean that older people present directly to a hospital that can provide them care, therefore reducing the delay from injury to admission to hospital. Takeaway 3 is about prevention, one of the hardest things to address even in countries like Australia and New Zealand. But here is a thought specific to these patients with a fragility hip fracture. Removing referral for bone density assessment after fragility hip fracture and in-hospital initiation of a low-cost medication for osteoporosis would eliminate a barrier to recommended care and remove a difficult choice for patients and families on how to allocate their limited financial resources. Thank you, and happy to take any questions.
Thank you, Elizabeth. As always, the researches that you are conducting they're very applicable, no? Not only to the setting in Australia, but also to the setting of low to middle income countries. So after Paul's presentation, we would be happy to ask Elizabeth some issues or questions regarding her presentation and how can this be adaptable to our country. So next, I'm happy to introduce our next speaker, who is a very good, also a very good friend of ours. He's been well known in the Asia Pacific region for pushing the advocacy of osteoporosis and fragility fracture care. If you will ask all the champions around the region and also globally, the name Paul Mitchell won't skip you. Paul is actually an associate professor at the School of Medicine of the University of Notre Dame in Australia. He is an honorary departmental senior research fellow of the Nuffield Department of Orthopedics at the Oxford University Rheumatology and Musculoskeletal Sciences. He is a member of the Capture the Fracture program of the IOF's steering committee, Capture the Fracture program, and is also a member of the Asia Pacific Consortium on Osteoporosis. And he's also the project manager of the Asia Pacific Fragility Fracture Alliance, as well as a board member of the Osteoporosis New Zealand and the past communications chair of the Fragility Fracture Network. So I think his presentation is very applicable at this time that we want really a strategy on how to promote osteoporosis care and fragility fracture management in the Asia Pacific region, especially targeting into the low to middle income countries. So it's a great pleasure to introduce Professor Paul Mitchell. Paul, take it away.
Thank you very much, Iowin. I hope you can hear me well, and thank you for that very, very kind introduction. Lovely to see you, Elizabeth, as well, and all the other friends on the feed from the Philippines. So I'm going to talk to you about pyramids, which sounds as if it's something from another part of the world, but all will be revealed fairly shortly. So Iowin's kindly introduced all of my affiliations and disclosures and whatnot, which is there. I'm going to take a whistle-stop tour and break all the PowerPoint rules of presenting too many slides in 15 minutes. So friends, please don't feel you need to scribble down notes. I'm very happy to share the slides with Iowin afterwards, who can share them with you all. So we will move at quite a pace through this. So something that's become of great interest to me since about 2017 was this concept of a new demographic era that we're entering into. The United Nations produces beautiful data every couple of years on the shifting demography across the planet. And I want to share a little bit of that with you first, which is really the tenet of why fragility fracture care and prevention matters. So every couple of years, the UN produces this wonderful document, the World Population Prospects Demographic Profiles. And in this is a ratio called the old age dependency ratio, which is a measure of the proportion of the population that are classically known as seniors, i.e. those folks over 65, compared to the population aged 15 to 64. Now, I'm not sure being over 65 classifies you as a senior, because I'm 55 next year, so I'm not sure that I'm having that, but it's a pretty rudimentary measure of how our population is aging, and there are some stark illustrations that will follow. So the way in which these old age dependency ratios are presented is the number of folks 65 and over, or notional dependents, per 100 people of notional working age, those aged 15 to 64. And this data is available in this tome here of 883 pages for the entire world, all the world regions and all the countries. So the next slide gets a bit busy because it tells you the data for the world and then all of the world regions, and then we'll have a look at the Philippines as well. Okay, so, oh good, to start with, the animation is working. So UN has this data from the year 1950 historically all the way through to their mid-range population projections out to 2100. Okay, so they have high projections, low projections. These are the mid-range projections. And what this is telling us is that in 1950, for the entire planet, there were about 8 or 9 people, in fact 8.4 people aged over 65 per 100 folks who were aged between 15 and 64 years of age. Now, you don't need a PhD in health economics, mathematics, or anything else to realize there's a point of inflection here. We're pretty much living right in it. So in the year 2020, that 8.4 per 100 seniors, 8.4 seniors per 100 people of working age had increased to just over 14. And by the end of the century, it's going to be nearing 38, okay? This is where the graph gets a little bit busy, so bear with me. Oh, good, yeah, there it is. So all of these different lines are telling you red remains the world, but what's going on in the big world regions. And for ourselves, Asia is the thick gray line that you can see there coming across your screen. So in Asia, there are about 6 folks who were 65 or over per 100 folks aged 15 to 64 in the year 1950. There's a point of inflection, probably about 2010, and it's heading rapidly north, such that by the end of the century, so if you look at the grey line, the 4th one down on the far right there, that by the end of the century, it's more than 45 seniors per 100 notional workers. And you see that Europe and North America got older earlier, and Africa will get older later. But across all of Asia, that's the picture. So let's have a look at what the Philippines looks like. Now, the Philippines, like lots of other middle-income countries, has this interesting sort of hockey stick arrangement here, where in terms of the number of seniors per 100 workers in 1950 was about 7. There's a little tiny dip there, but you can see the point of inflection around 2010, and you guys are heading rapidly north by the end of the century. There's a couple of messages from this. Number one, if you're going to get busy with fragility fractures and putting in place preventative strategies and management strategies, right now is a pretty good time to be doing it. There's another cool thing that comes from this is if you were to compare where the Philippines features with, say, Europe or New Zealand and whatnot, your population has a several decade advantage relative to some of the older societies in the world of what is yet to come. And I think that can be a really potent discussion. And I've shared these graphs with Iowin when you're in discussion with policymakers to say, look, we've got a bit of a heads up here. We need to get very busy with managing the consequences of fragility fractures now, but there's a bunch of stuff that we can do throughout the life course that could have really massive benefits in the latter half of the century. And I'll come to that in a little bit. So these wonderful resources from the UN are so powerful and are really, in my experience, can get policymakers' attention pretty quickly. So let's get through these slides as I have 12 minutes left. Now, I'm probably preaching to the choir here that more older folk equals more fractures, because age is a principal determinant of fracture, unless we do something about it. Back in 2017 with IOF, we wrote this wonderful IOF compendium of osteoporosis with Cyrus and Philippe and all the wonderful people there. And there we noted that in 2010, the number of folks over 50 who were at high risk of osteoporotic fracture was estimated to be 158 million. And if we don't do something about that, that's going to double by 2040, which is not a good outcome. In Asia Pacific, by 2050, 1.3 billion of us will be aged 60 years or older, which will definitely include me, and more than 250 million of them will be aged 80 years or older, which, if I'm lucky enough to still be around, will also include me. In China, if we take that huge populous country there, in 2015, the EPI said there were 411,000 cases of hip fracture, which is going to more than double by 2050. So we have an epidemiological emergency, as our dear friend Professor David Marsh would say, that we need to get stuck into now. Another quick bit of epidemiology before we get to the pyramid. I really commend this study to you. And Elizabeth's colleague, Rebecca Ivers from Sydney, was one of the very many contributors to this fabulous global burden of disease fracture study published in 2021, which looked at the global incidence of fractures and prevalence and years lived with disability in the year 1990 and 2019. And this is for all 204 countries and territories on the planet. And in the auxiliary data that's available online, the Philippines is there. This was the first time this was done. The GBD study, Global Burden of Disease Study, I think they look at more than 130 diseases. This was the first time they looked at fractures. You won't be able to read it on there, but I think something that's very important on this slide is the fact that the funding was from the Bill and Melinda Gates Foundation, which I find very, very interesting. That means it's on their radar. Anyway, what did Rebecca Ivers and friends find? So now, I should say before I go into this, this is all fractures at all ages across the whole of the planet. So this isn't just fragility fractures, it's all fractures, but bear that caveat in mind. So in 2019, the GBD group estimated there were 178 million new fractures at all ages in 204 countries and territories across the world, marking a 33% increase since 1990. So that's incidence, right? If we look at prevalence, then in terms of prevalent cases of acute or long-term symptoms of a fracture, so people who had a fracture in the past or are living with the sequelae of it, 455 million cases, 70% up since 1990. And if you look at years lived with disability, pretty much a correlate of the previous bullet point, 25.8 million years lived with disability in 2019, an increase of 65% over 1990. Mega numbers. Now, we will all remember the wonderful study from Professor Canis and Professor Yonell, published about 20 odd years ago, that said there are 9 million osteoporotic fractures in the world. These were the classic fracture types and some pretty conservative estimates at the time. So what is this study telling us in terms of fragility fractures? Well, the authors identified what we all know, that age-specific incidence becomes evident around age 50 to 54 years in females and 65 to 69 in men. And in both sexes over the age 80 years, things go north very rapidly. But if it is the case that a simple 50.001% majority of the fractures occurred in older adults where old is seemingly age 50, again, not happy with that, that would mean there are about 89 million fractures occurring in people in the year 2019 who are over 50. Let us even suggest maybe only 50% of those are fragility fractures and the rest are people falling off of roofs, road traffic accidents or skiing or whatever else. That would suggest to us the actual number of fragility fractures right now will be in the tens of millions in the world. So I think, whilst not absolutely definitive, quite reasonably the scale of this problem is increasing at a dramatic rate of knots. So the other thing that's very important from this GBD study was what the authors said we should do on account of the findings. And there were 4 sets of recommendations. Firstly, they said, which will be music to all of your ears, because the majority of these 178 million fractures occur in older people, we need to expand screening and treatment of osteoporosis down to the bottom bullet, because as an FFN devotee, where goes osteoporosis goes falls, and where goes falls goes osteoporosis. We also need to look at interventions to reduce falls risk. But then in the middle is this second bullet, that we need to encourage exercise and diet that promotes bone strength throughout the life course. So I shall rapidly come to that point. Luckily or unluckily for us, The third set of recommendations said that in countries that have the highest age standardized disability burdens, which happen to include New Zealand, where I am currently located, and Slovenia, there should be a focus on development of evidence-based policies to prevent fractures. That will apply with this demographic shift across the planet to pretty much all countries in due course. So I really commend that GBD study to you. What fascinating and interesting reading. Right. So to paraphrase the guys in NASA a while ago, Houston, we have a problem. So what are we going to do about it? And systematic approaches to care and prevention of fragility fractures. Now, what I'm going to describe in the next 6 minutes, I promise, Iwan, so I don't run over, is a distillation of a huge amount of work conducted by many thousands of brilliant and devoted friends across the world that I can't possibly acknowledge by name all at the end, but I really appreciate their tremendous work. So where do you start? Number one, it wouldn't be an FFN session if we didn't talk about the Global Call to Action on Fragility Fractures, published back in 2018. And this says, because we've got a huge number and growing number of people who are sustaining new fragility fractures, we need great acute multidisciplinary care for people who have fractures that take them to hospital, excellent recovery and rapid secondary prevention for anyone who sustains a first fragility fracture or a second one or a third. Right, to the pyramid. At last we got there, Iwan, by slide 21. So this pyramid, or a glorified triangle, dependent on how you want to look at it, has been produced in quite a number of countries. First off, in the Department of Health for England, Prevention Package for Older People, Falls and Fractures subsection, which I had the privilege of being a very minor contributor to before I came down here to New Zealand. That had the top 4 strata of this pyramid: hip fracture patients, non-hip fragility fracture patients, people at high risk of sustaining a first fracture, and all older adults. In the years since that was published in 2009, various groups around the world have said, well, let's make this a whole life course approach thing. So we consider those adults, i.e. young people between 19 and older people between 64 years of age, and what we should be doing for our kids. And you can see on the right, something we did when we produced this for the Department of Health in England was to try to be able to summarize in a single slide a really complex piece of policy with a whole bunch of programs and initiatives and models of care and financial incentives and all the rest of it in a single slide to enable all stakeholders, be they policymakers, and there's a lot of P's going on here, policymakers, professionals, healthcare professionals and their organizations, patients and their advocacy societies, payers, private and public sector insurance companies, private sector companies, or indeed the philanthropic sector, to try to help everyone to get what we're on about with this strategy and where they fit in it. So at the very top, let's have a look at hip fracture patients. Now, I know that Iwan and colleagues have pioneered this fabulous national pilot hip fracture registry in the Philippines, becoming the 19th country in the world to have an existing or emergent hip fracture registry. What the pyramid says is we need clinical standards of care, and I'm quite sure that Elizabeth must have spoken to this about the ANZ ones, ANZ, Australia and New Zealand, and there are clinical standards of care for hip fracture patients from hitting the ambulance all the way to 120 days after admission, what needs to happen and when. And in order to try to standardize that care, clinical teams need registries so they can get feedback, and ideally feedback in real time, to say, how are we going against these clinical standards? So let's have a whistle-stop tour through what we've got. The inspiration for this was the UK NHFD, which was in fact inspired by the work in Scandinavia in the 2 decades before. The UK National Hip Fracture Database is now, was set up in 2007, published coincidentally, Elizabeth mentioned it, with the BOA BGS Blue Book, which had a very simple set of 6 clinical standards, published in 2007. That NHFD has now documented the care, benchmarked it against the NICE clinical standards for 800,000 consecutive hip fracture patients over the last 15 years. Truly, really fabulous thing. In Australia and New Zealand, we took a complete leaf out of the Brits book, and Elizabeth, Jackie Close, Ian Harris, loads of other wonderful people on both sides of the Tasman Sea in 2014 developed Australia and New Zealand guideline for hip fracture care. From that guideline were derived clinical standards, and that had 7 clinical standards with explicit key performance indicators sitting underneath each standard, so you can measure it, numerators, denominators, and then you end up with an annual report. And there's the latest one. So I will whiz, and there are 57 charts in each of these annual reports. This incomprehensible thing that is appearing on your screen, and if you're watching it on an iPhone you don't have a chance, but let me try to talk you through it. The top 4 bars are New Zealand averages from 2017 to 2021. Then all of the next little panel of bars, the second panel down, is the New Zealand hospitals named. Under that, Australian averages from 16 to 21, and then all the Aussie hospitals named. And what this tells you is, I've just chosen one of my favorite subjects, osteoporosis treatment on admission, on discharge, and at 120 days. And I'm going to run over by about 3 minutes, so I shall really motor on, I promise. And what we can see here from the key is dark blue says, were people on a osteoporosis specific treatment, bisphosphonates, denosumab, or teriparatide when they came in. Green is, yes, they were on calcium and vitamin D when they came in. Light blue is no bone protection medication, and the dark blue is not known. And what you can see is there's quite a lot of variation there. So that's admission. That's what it looked like on discharge. You can see quite a big shift, still tremendous variation across all those hospitals. And that's what it looks like at 120 days. So across the whole country on admission, 11% of hip fracture patients were on osteoporosis specific treatment. By the time they were discharged, 34%, not ideal, but 120 days, 43%. So we've got a lot of work to do to make that better. Should it be 100%? Probably not. Let's be realistic. Should it be 43%? Probably not. Somewhere in the middle, maybe 70, 75%, something like that. Okay. Very quickly, Asia Pacific Fragility Fracture Alliance, this wonderful alliance of all of these 7 organizations here, 3 global, 3 regional. We published a couple of years ago, no, last year, 2021, a hip fracture registry toolbox, which I think Iowan has shared with you all. This is a distillation of all the experience from 18 hip fracture registries around the world to try to help friends avoid that horrible blank sheet procrastination syndrome and learn from the experience of others who've gone before. So do have a read with that, some fun YouTube channels there. And as I say, don't need to write this down. Iowan will share it with you later. You can have a read of the hip fracture registry toolbox. Okay, next up, going super fast now, Iowan, and if you need to cut me off, just shout. Fracture liaison services. We know that half of hip fracture patients have fractured another bone in the months or years before they broke their hip. So let's pick them up when they break the bone before they break their hip and stop them from breaking their hip. Fracture liaison services, you're all very familiar with this, the so-called osteoporotic career, given that we know half of patients go through this experience and tell us they're coming by virtue of breaking something else before they break their hip. So I had the chance to be involved in Capture the Fracture, wonderful IOF initiative that was launched 10 years ago. Can't believe it, 10 years ago. And our wonderful friend, Professor Cyrus Cooper, basically said, we think this is the single most important thing in the world we can do to try to stop spiraling fracture rates. So worth going and having a look at that 2012 World Osteoporosis Day report. Very, very quick self-reference to a recent fracture liaison paper. Here's this thing. For 4 decades, since the 1980s, we've known that half of people who break their hip have broken something before. For 3 decades, we've had pretty good and safe and effective treatments to be able to reduce fracture risk, secondary fracture risk significantly. During the last 2 decades, since the turn of the century, this fracture liaison model of care has been demonstrated. And now there's consensus amongst many, many groups across the whole of the planet, IOF, FFN, numerous regional groups, national groups, and many in the Philippines saying, let's make these fracture liaison coordinator-based services the norm. And so that's what that says there. Next up, nearly there, Iowan, I promise. So if you've done the top 2 parts of the pyramid, okay, and the beauty of this is it kind of follows a logical sequence and how, you know, deploying finite healthcare resource when one is competing for healthcare dollars against all the other very other laudable causes in the health system. Next up is people at high risk of suffering their first fragility fracture. How do you go about this? Tricky. We don't have the absolute answer, but what we do know is there are a significant number of people with very obvious medical treatments or obvious pieces of history that say they're at high risk of being the half of hip fracture patients that haven't broken a bone in the months or years before they break their hip. So, for example, people who are being treated with glucocorticoids for very good reason, but that have the adverse effect on their bones. People being treated for breast cancer with aromatase inhibitors with adverse effects on their bones. Men being treated with androgen deprivation therapy, which has adverse effects on their bones. If people are being treated with those medicines, we know that because it's on a database somewhere. Similarly, if they have other obvious risk factors for fracture and they haven't fractured yet, rheumatoid arthritis, COPD, HIV, so forth, then those people can be found. This we said in an IOF World Osteoporosis Day report in 2016, and more recently, my friend Professor Manju Chandran from Singapore, and IOWIN is part of this, the Asia Pacific Consortium on Osteoporosis has developed clinical standards to address the secondary prevention piece, but critically this primary prevention piece. So if you go to www.apco.bonehealth.org, you can read all about that, which is a way of then going down to that next stratum of the pyramid. Then what do you do? Very nearly there, Iwan. I'm going to steal 5 minutes of your time. For these wonderfully lucky people who've got to 65, who have healthy bones, and younger people who have retained healthy bones, how do you develop public health messaging that can ensure those bones remain healthy? I'm just going to offer you a couple of insights in that regard, or thoughts, really. It's not so much an insight. Osteoporosis New Zealand is one of the organisations I'm involved in, and we decided, and our brilliant executive director, who I met at the FFN Congress recently, Christine Gill, a couple of years ago, just before COVID hit, is we needed to have a consumer or public-facing brand that was more engaging than Osteoporosis New Zealand. And thus was created Bone Health New Zealand. Might sound like a very semantic distinction, osteoporosis, bone health, positive, perhaps negative. Different connotations. So Bone Health New Zealand is a wholly owned brand of Osteoporosis New Zealand. And there's a couple of circles that describe the relationship there. We licensed from our friends in Australia a wonderful tool called Know Your Bones. So if you go to knowyourbones.org.nz, knowyourbones.org.au, there's this wonderful online tool that will give patients the capability to produce a report for themselves to say, what's my bone health looking like, that they can take to their GP or their specialist or whatever else to discuss. We ran a very, very comical advertisement during COVID with a dancing skeleton. I wish I could play it, but I don't have the time. If you go to YouTube and put in Bone Health NZ, you can see our disco dancing skeleton there. The serious point was we played this on our TV NZ3, who gave us a slot. And over 2 weeks, when this little commercial aired, 5,000 New Zealanders, or 1 in 1,000 of the population, went and did the test. Very simple message, very simple call to action. People can be interested. And then the very, very final thing, and this actually really applies, and it could be really valuable to a young population, as the Philippine population is right now, is getting our kids to achieve peak bone mass. We don't have a 100-year study, randomized controlled trial that started 100 years ago to tell us what does this do. We've got some interesting computer modeling, some of which was published about 15 years ago, which varied a number of factors. One was if a kid achieves their genetic potential for peak bone mass compared to their peer who achieved 10% less than their genetic potential for peak bone mass, what does the computer tell us? The computer told us that the kid who achieved 10% less of their genetic potential peak bone mass would develop osteoporosis 13 years younger than their friend who achieved their genetic potential. So putting very simple messages in the school curriculum for science, health, and exercise could be a very potent tool, actually, albeit a very long-term burn, to have benefits in the 2070s, 2080s, 2090s, and 2100s for your young population right now. So, in conclusion, you'll be very pleased to hear, Iwan, that Iwan was one of the co-authors of this lovely paper. Again, I think Iwan's sending you the links to this, a review from APFA, which was the Asia Pacific Fragility Fracture Alliance, on wonderful progress across the Asia Pacific region in the last 2 and a bit years, since just pre-COVID. Wonderful conclusion for the China National Fracture Study, fantastic, massive study, survey study in China. And what this says was, in emerging economies, transport injuries occupied center stage for research and policy efforts to unintentional injuries, and fragility fractures were nowhere to be seen. Well, what is clear from the CNFS and the experience you've got in the Philippines and other friends across the whole of the region is that ain't so. Now is the time with that demographic shift. If you guys can get on top with hip fracture registries, as you're doing, and FLS right now, you're not going to be facing the huge challenges that we are in the older societies, where we've got this absolute tsunami of fragility fractures, because you've got a 2 or 3 decade run on it. So there we go. There's the pyramid again. And I'm there, Iwan. Thank you so much for indulging me. Sorry for stealing 8 extra minutes. I do hope it hasn't thrown your program into complete convulsions. If anyone would like to talk to me, Iwan can connect you. I'll be delighted to respond to any of your questions. Paul, over and out.
As always, thank you very much, Paul. It's always a delight hearing from you, especially those holistic perspective, as regards to strategies carrying out the programs regarding osteoporosis and fragility fracture. Actually, the reason why I really wanted to hear from Elizabeth and Paul, as I don't know if the audience have noticed, it's really very contrasting, but in effect, connected talks, with Elizabeth's study centering on the challenges and of low to middle income countries in terms of treating hip fractures, and then here's Paul giving to us a complete strategy, on how to address these problems. My first question would be maybe to Elizabeth. I'll let Paul catch his breath first. Okay, Elizabeth, in your interviews, in your data processing, what do you think would be the, if you have to pick as regards to what are the glaring challenges facing low to middle income countries, what would be these maybe 1 or 2 problems that we can really address, for our country in the Philippines?
So thanks, Erwin, and delighted to be here, and always love listening to Paul do a policy perspective in 15 minutes. There's a couple of things. One, I think one of the really big challenges, which I'm not sure that individual clinicians are able to address, is the patient payments, the lack of a universal healthcare system in a lot of settings. So that's a really big barrier, and I don't think that individual clinicians can do anything about that. That's where the policy aspect comes into play, and I think feeds into Fragility Fracture Network and their 4th pillar around policy work. So when I think about what individual clinicians can do, I always come back to collecting data. If there's a capacity to quantify the burden, then there is a capacity then to make a case for providing, whether it be a hip fracture registry or fracture liaison services. Without quantifying the burden of those fragility fractures at any hospital, it's really hard then to compete against all those other things that are competing for attention, whether it be by the organisation, the administrators in the hospitals, or by the policy people in government.
Thank you, Elizabeth. I think that's a very important point. Maybe one of the main reasons why me as an affiliate in the university, I'm really pushing to have studies registry, because as you've mentioned, quantifying the burden is really it's really a must to push for this advocacies, as we call it, to have policy changes in the government. So I think that's a very valid point. Now, to Paul, I would just like to ask Paul. I know it's always a point of discussion that maybe this strategy might work for high-income countries like New Zealand or the UK or Australia, but in reality, is this really applicable even to low to middle income countries? And if you would suggest what level of the pyramid is the best way to present to the policymakers? I know there's the hip fractures and there's the figure 5 and 6, but you being an advocate, seeing things around the Southeast Asian region, what would be the best level for us to present to the decision or the policymakers with regards to the pyramid?
No, that's a really good question, Iwan. I think one of the most useful things to do is just to connect with policymakers on a human level. Having had the opportunity to speak to ministers of health in quite a few countries, pretty much everyone knows someone who's broken their hip. I mean, you know a lot, Iowin, because you've fixed hundreds of them, right? But pretty much everyone knows someone who's broken a hip. And I think I remember a very wise piece of advice I was given by an ex-bureaucrat in Canada who was a chief of staff for a health minister. And he said, there's this thing called the curse of knowledge he would describe, because on a Friday afternoon, his health minister would have all of the wonderful folks from 6 medical charities come in and see him. And they would all have 10, 15, 20 minutes each. And what the tendency would be to do is for professors and associate professors and very experienced doctors and nurses to use, say, the 10 minutes, blasting the poor politician with 8 minutes of the problem. And then by the time you get to the solution, only having 2 minutes to chat. And then you've lost it. So I think number one, it's really framing the debate. It's having an elevator pitch is really important. So, you know, we talked about this in various countries. In the UK, our elevator pitch, like when I lived in Britain, was, right, good morning, Minister. We currently have 80,000 hip fractures a year. Half of them fractured something before. If we treated them when they fractured firstly, we could have prevented 20,000 fractures and saved you £400 million. You interested? Right? Simple things like that, because then what's he or she going to say? Well, no, as a matter of fact, no, I'm not interested. It's getting that hook with the policy piece. And then actually, I would say, you know, if there's two pictures I could get in front of them, and actually also to say, Minister or Minister's advisors, I want you to take 3 things away from this chat that if you can bore into your brain. One is the picture of the old age dependency ratio, because it visualizes the silver tsunami in a way that's the why all of this matters. The next is then the pyramid piece, is to say we can start wherever we want on this pyramid. And in older countries, it makes a heck of a lot of sense to throw all of our resource at the top, because if you're Japan or Korea, you've got a gazillion hip fractures right now. So you might want to say, we've just got to focus on this because we're quite literally managing an epidemic. You might say in the Philippines, well, actually, we think we should start here with the clinical stuff. The top 3 strata of that pyramid are clinical. The bottom is clever information technology, clever social media, and people that are a quarter of my age who can actually do this stuff really, really well to engage people en masse. But to say to the minister, you know, what do you think? Well, you know, this is what we think, but this is the universe of people. And then maybe have to hand some of those costs of where they are now and where they're going to be. And say, these are the 3 things I want you to remember about this conversation, Minister. And then you start to have, if you can achieve in that first 20 seconds, 20 to 60 seconds, piquing the minister's interest, then you've got half an hour. And then half an hour leads to half a day, leads to all sorts of other stuff. So, you know, it's going to be very dependent on who the minister is. But if you can, coming back to my initial point, you know, I've said it to several, and it's quite private. So can you picture a senior family member or friend of the family who's broken their hip? And if they turn around and say, well, it's Auntie Rose, say, well, can you recall what happened to them? And you hear that it's a spiral of decline and blah, 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 and blah, blah, blah. It's like, right, okay, well, let's stop that happening. You know, in some instances, in some places, the minister has said, yeah, my mum's got osteoporosis. She fractured yet, sir? No. Good, let's keep her there. Has she fractured already? Okay, let's stop her fracturing again. That kind of stuff, it's connecting on a human level.
Thank you, Paul. It makes it extra challenging on our part because we still don't have a formal Minister of Health right now. It's quite ironic, but I think your suggestion regarding clever information technology, now focusing on the bottom part of the pyramid, is really something to think about. Especially we are big into tangible things, and it's very difficult to to promote something which is a silent disease and osteoporosis. So maybe a sort of innovation in technology that would sort of make it more palpable to the masses, to the families, and to bridge that information gap. It's something that we can look into. No,
Just a quick point, Iwan. Am I still correct? Because I know that Facebook becoming Meta means things are changing, but am I not correct in thinking that the Philippines was one of the most Facebook or social media connected countries on the planet? Was that right?
you are correct. We
Okay,
are.
I'll
yes.
put a couple of things in the chat to that, and I'll go quiet.
Oh, thank you, Paul. I know you have ideas flying in your mind, which is always very applicable to whatever condition that the country has. So that's very helpful. I know. Now I'll go back to Elizabeth. I think we have 12 more minutes in our Q&A. For the audience, my chief resident, Vince is there. If there are any questions, no, just feel free to ask. Okay, but I have several questions as well. No, prepared for this. For Elizabeth, I know. I just want for the folks here in the Philippines to hear your situation there in Australia and New Zealand is quite different from the UK. No, in terms of implementing your hip fracture registry. In the UK, there is the National Hip Fracture Database, which I think is mandated by the government. But in Australia and New Zealand, it's different. No, it's more of research based. I know you're really into this because you were, as you've mentioned, the hip fracture registry database, and I think you have the same challenges as we have here in the Philippines in terms of implementing, at least in some parts of Australia. Can you sort of elaborate on some of the challenges that you've also been experiencing there in Australia, New Zealand, in terms of expanding your hip fracture registry? Because as you've mentioned, as Paul mentioned, we really need to have to quantify the burden. And data gathering is really very important. Without data gathering, I don't think we will be able to push for these changes. So,
thanks, Erwin. The Australian and New Zealand registry are not driven as a government initiative like the UK National Hip Fracture Database. So it's very much embedded into their health system, and the ANZ HFR started as really as a research project. One, there were a couple of reasons. One, we got an initial tranche of funding, which was attached to a Bupa Health Fund grant. So that was a competitive grant that allowed the ANZ HFR to develop its guideline. It allowed to start work on the standards and to develop the minimum data set, and also to employ me as a registry manager for a few hours. And we started with me at 14 hours or 15 hours a week. So it wasn't a lot of money, but it allowed us to get starting and start to recruit. The other reason in Australia and New Zealand for going through that research aspect and sitting with the Medical Research Institute is because we have national legislation around data privacy for health conditions. And one of the ways that we're allowed to collect and hold identified data across our state boundaries is by having an ethics review and approval. So if we didn't have that research ethics review and approval, then we would find it very difficult to move quickly to get sites on board contributing data to sit within a medical research institute that doesn't sit within our health system. So that was another reason for taking it. So I suppose the learning from that is that context is everything. And if new places want to start with the concept of the registries, then it's really about looking for what approach is applicable within the setting that they're in. So what works in Australia and New Zealand from that governance perspective or starting a registry isn't necessarily going to work in another country that might have a health department initiative around registries, and see the hip fracture registry as something that they could embed in the health system more generally, which is what Sweden did. Sweden was very much a government initiative around clinical quality registries because they knew that they would pay for themselves. So different models in different environments and different political contexts. And I think it's really important to remember that, because it will help frame the message. So the message that Paul was talking about, whether it be the elevator pitch or the business case or talking to the bureaucrats, it's about framing the message so that it's relevant to the audience. And a bit like what I said about what you collect, you know, when you collect data, think about the audience that you're going to use that data for. Even if it's me as a resident, a junior resident who's doing a term in the emergency department, I could sit and I wanted to work on a quality project to get people admitted or to surgery more quickly. And I needed to make a case to my orthopedic department chief. It might be that I sit and I say, in the 8 hours of my shift, I'm going to count the number of people that present to hospital and I'm going to collect two things. One, were they admitted? Two, was this the first hospital they presented to? And if this wasn't the first hospital, then how many other hospitals had they presented to before they got to us? You know, and so that information can then form the basis of an argument for a particular improvement project. So audience is really important.
Thank you, Elizabeth. I think that's a very nice insight. No, as you've always mentioned, no, even small data can trigger big changes. So it doesn't mean that you really have to get complex data. I think we have a question from Carla, Dr. Carla Araneta. Carla, can you post the question?
Hi, sir. Hi, Elizabeth. Hi, Paul. Hi, it's really good to see you again. One of the challenges I think we spoke about, because we are starting the pilot hip registry involving multiple centers here. I remember speaking with you, and one of the challenges we talked about was the sustainability in terms of, you know, funding the registry and everything. And our study is, you know, funded by the Department of Science and Technology, so it's got a shelf life of like 2 years. What I wanted to ask was, when you were running the registry, did you see a level of sustainability happening within the institutional or hospital level of them maintaining their own internal audit based on the registry data? Because if we can't sustain it on a multi-center level, then maybe these centers could be doing it on their own eventually. Did you see that happening on the ground?
Yeah, thanks, Carla. It's a good question. I think individual hospitals can continue on their own, but there is inherent value in the comparison. So that's the benefit of the registry, is you get the comparison between all of the different competing hospitals, and no one likes to be at the bottom, and that drives change. So there's a comparison which is helpful. From a sustainability perspective, when we needed to work quite hard at looking for ways to get additional funding. So we knew it was kind of a circular thing. We knew that we needed to have hospitals contributing data, because if hospitals were contributing data and we could report that, then there would be value in what we were doing with the registry and the data collection. We also knew that we needed to get funding from a more sustainable source than writing research grants, you know, year in, year out, because that's just onerous. And so we took an approach of going, okay, we've got state health departments and we've got a federal health department. It's easier to work with a state health department. So let's see if we can pick off a little bit, really small amounts like 25,000 Australian dollars a year from one state government health department. So that's not a lot of money. And we took $25,000 from 3 different state health departments, which then allowed us to go to the federal health department and say, we've got contributions from states, will you match that? And so that then, and once we had that, there was a financial sustainability for the registry, because we had $25,000 for 3 years from one state, and then from 5 years from another state, and then we had annually from the federal government. So that was the financial sustainability, but that was really predicated on having people contribute data and reporting that, so that there was the competition to improve care.
Thanks, Elizabeth. Paul?
Yeah, just a
something.
couple of things, Carla. Number one, I've just put into the chat that we have this interesting organization in New Zealand called the Accident Compensation Corporation. Sounds like a company, right? It's not. It's actually a kind of government entity. These guys are responsible for a no-fault national injury prevention scheme, and they are a crown entity, a state entity that pays for all the hip fractures. So they've been absolutely fabulous. We as Osteoporosis New Zealand have been talking to them for a decade. Since 2016, they've been funding the registry here. We're tiny compared to Australia and minuscule compared to the Philippines. We're 5 million, Australia's 25 million, you guys are 125 million. But these guys have funded the registry from the get-go and a whole bunch of other stuff around it. So it's kind of following the money trail is an important thing. I often use this expression that if one is to achieve, and I think Elizabeth alluded to it, real change, when we're faced with the demographic miracle of the last century and the aging of the baby boomers, which is absolutely fabulous, if we're going to make something of this for ourselves and them and our kids and grandkids and everything else, we need to have multi-sector, multidisciplinary collaborations. And I call it the 6 Ps, right? So the Ps are policymakers, professionals, healthcare professionals as individuals and organizations, patient advocacy organizations and individual patients, payers, public and or private sector insurance companies, private sector companies, whatever they may be, DEXA companies, pharma companies, whatever else, and philanthropic organizations. So there's 6 Ps there. Imagine a hexavalent atom, right? That are orbiting around the central one. That engaging all of those folk, I think, is really important. In terms of the policy debate and seeing where the levers are and being opportunistic. I think Elizabeth has referred to the fact is, getting these things off the ground. It's not a linear trajectory of a rocket. You take what you can get from where you can get ethically at an appropriate time. Another thing that I'm casting my mind back to 2007 with the UK, when we set up the UK National Hip Fracture Database, and the guys in Australia and New Zealand database have done this beautifully ever since, which is people feel like they are lone wolves in the wilderness trying to achieve this when you are just 14 or 16 hospitals in a massive country doing this stuff. Getting together is really important. And, COVID messed things up a bit, but we could do it virtually, which overcomes some of the tyranny of geography and distance in the Philippines. But having these fracture festivals of bringing together the teams that are doing stuff to share their experiences, frustrations, solutions. But then when you do that, get some politicians along and get them in the room and get them enthused, which is really important. And then something else that we're trying to do, and I've been talking to friends at IOF and international organizations about this, we've got some policymakers here who've been fabulously supportive. The Japanese friends too. There's some cool stuff in Thailand, is trying to create international fora where those folk could have the opportunity to speak to your folk and folk in policy in other countries to say, as a policymaker in country X, this is why I think this is a no-brainer. Who's a better person to influence a policymaker than a policymaker from somewhere else maybe? So that's just something else to throw into the mix.
Thanks, Paul. Thanks for that very nice insight. Really something to think about moving forward. I think I'll just read this question aloud from Obet. Is there a way to automate the registry where the data can be appended with minimal human intervention, so it will be less expensive? So maybe I can comment on that. It will all depend on maybe the data that we are getting, because some data will really need the ethics approval, especially if it's patient-centered. But I think for the country like the Philippines, I think we should really look into this. An easier way to get data. And this is one thing that I really want to offer even the UP Cebol administrators of, maybe we can create an app where we can get maybe not really the patient level data, but at least the institutional level data where it's not really covered by ethics approval. And maybe, as Elizabeth mentioned, simple data from simple things maybe can trigger big improvements or big policy changes. So yes, Paul.
Yeah, just another quick thought, Iowin, and do shut me down because I talk too much. When we started the hip fracture database in the UK, one of the first conversations we had was to say, look, there's been a long established myocardial infarction national audit project, a mega heart attack database, right? So wouldn't it be cool if we could persuade, and these guys were like 5 or 10 years before us, wouldn't it be really cool if we could persuade one of their board members to come and mentor us on how we do the NHFD? And this wonderful professor from Liverpool University came and helped us with the full support of the MyNap database. So if you have other well-established national databases, probably an obvious one is your joint registry, which I would imagine joint registries are pretty well established in lots of countries, right? No, oh, okay. But if there's a great heart attack one, or something cardiovascular, is whether one could persuade one of the eminent leaders of that group to say, what are the do's and don'ts of getting a registry really moving, expanding participation and getting political buy-in? That gentleman's opinions were invaluable and saved us from doing a lot of the wrong things, and it pointed us in the direction of doing a lot of the right things.
Thanks, Paul. I think if we don't have any time restrictions, we can talk all day. It's always when I always when I talk to you guys, my mind is always stimulated to think about things that I never imagined to to think or to strategize here in the Philippines. But due to the interest of time, I just like to inform everybody that Elizabeth has been very helpful in our pilot hip fracture registry, as well as Paul. And Paul has offered to at least offer the strategy that they are doing, the pyramid strategy, and for Bone Health New Zealand, to at least we have a conversation on how to adopt it in the Philippines. With their guidance, I think we really need these strategies, this holistic thinking, in order to prevent fragmentation of things. Because I think everything is being done in silos, and that's the least that we need to we want to improve on, especially now that our economic condition is really problematic. Okay, so with that, I know it's 7:30 p.m. in New Zealand, and it's around 4-5 p.m. in New South Wales. Thank you, guys, and we really enjoyed all the information and in your presentations, and I hope we can invite you again sometime. Maybe we can already have a policy change that we can really we will need your help in promoting this to our policymakers. So thanks, Paul.
Lovely to see you. Thanks for the chance, Iowin. Lovely to see you all. All the best. Be in touch. Take care. Good night. Bye.
Bye.
Okay, so I hope you learned something from that from those presentations. These are the the champions that we're always dealing with the Fragility Fracture Network. Innovative minds that can really help us in pushing for programs in our country. So they have offered their help to help to improve our advocacy as regards to orthogeriatrics and FLS in the Philippines. So moving on, we will proceed to a company supported lecture by Amgen Zuwilig regarding updates in osteoporosis care. So it's my pleasure to introduce one of our graduates from the UP Department of Orthopedics. I know that she's into tumor. That's really her line and her fellowship. But I'm very happy that she's also very interested in improving the system that we have in the Philippines as regards to fragility fracture care. So it's my pleasure to introduce Dr. Carla Araneta. Carla?
Hi, sir. Thank you so much for the introduction. And yes, I love tumor, but fragility fractures have also become very close to my heart. Okay, so good afternoon. Again, I'm Dr. Carla Araneta, an orthopedic surgeon. And today I'll be tackling severe osteoporosis and the role of denosumab, hopefully in 15 minutes or less. I'll be speaking, of course, from the perspective of an orthopedic surgeon who regularly consults her endocrinologist. So I just want to make sure the slides are okay. No issues? Okay, I'll move on. For my disclosures, my talk today is supported by Zuwilig Pharma Therapeutics, Amgen. To review one of the messages that Paul Mitchell was emphasizing earlier, the Philippines is projected to transition to an aging population between 2025 to 2030. So that's actually 2 years from now. And by aging population, we mean that around 7 to 13% of the total population is age 65 or older. No, this is not a graph of the peso-dollar exchange rate in the last year. This is a population projection of the percentage of the elderly based on more recent UN data. So we've actually already started transitioning to an aging society since 2019. And by 2050, with more than 20 million people being over 60 years old, almost double the rate we have now, we will be considered an aged society where almost 20% of the population is aged 65 or older. So due to the growing aging population and the increased life expectancy, the prevention, diagnosis, and treatment of osteoporosis is quickly becoming a national health priority. So according to local data, 80% of Filipino women, that's a lot, and 60% of men aged over 70 are at higher risk of developing osteoporosis. While we're already familiar with the definition of osteoporosis as being a disease characterized by low bone mass, as measured by your T-score minus 2.5, severe osteoporosis is further defined by the presence of one or more fragility fractures in addition to your low T-score. So this is just a reminder that other risk factors contribute to fracture risk and not just your bone mineral density. So let's put what we know to a test. This is a case of a 77-year-old female, very active community ambulator who fell on her left hip after slipping in the bathroom. So we see that she sustained a femoral neck fracture over her left hip there. So the first question is, while the patient is admitted, what tests will you order? So actually our tests should focus on ruling out secondary causes of your low bone mass. It's an indispensable step when you diagnose osteoporosis because they can distinguish between this condition and other metabolic diseases of the skeleton, which can present a clinical picture very similar to that of your osteoporosis. So your first level tests include the following: your ESR, your CBC, serum calcium, phosphate, alk-phos, CREA, total protein and albumin, as well as your 24-hour urinary calcium. Normal results for these tests exclude up to 90% of the secondary forms of osteoporosis. If suspicious for other etiologies, based on your patient history, your clinical exam, or the first level labs, second level tests will help us determine that. So like your TSH, PPH, vitamin D, and your serum electrophoresis as appropriate, these can identify possible causal factors and hence direct you towards an appropriate treatment. So moving forward with the case, the patient had unremarkable lab findings, which is usually expected in osteoporosis where mineralization remains normal. The patient then underwent a cemented total joint replacement during admission. So the next question is, will you prescribe a pharmacologic treatment for her osteoporosis? A, no, but non-pharmacologic treatment can be initiated. B, not until osteoporosis is confirmed with a DEXA scan. Or C, yes. So the answer here is actually yes. We do need to initiate non-pharmacologic treatment, but we can also start your anti-osteoporotic medication already without confirmation of a DEXA scan in this patient. And this is very much supported by evidence. So this is taken from the Orthogeriatrics book by Paolo Falacci and Professor David Marsh, and very explicitly states that all European and international guidelines do not base the need for your treatment on the diagnosis of osteoporosis based on the T-score, but on the risk of fracture. And what more can influence this risk than the occurrence of the fragility fracture itself? So circling back to our definition, an elderly patient with a fragility fracture should automatically be classified as having severe osteoporosis independently of other risk factors. So what interventions will we prescribe? Non-pharmacologic management are as follows. Giving up smoking and abuse of alcohol and choosing an active lifestyle are very important. Programs that act on fall prevention and the risk factors for fall are also essential. But what I will delve a little more into about is the adequate nutrition and vitamin supplementation, because the average Filipino is actually not getting enough calcium in their regular diet. It's also been found that older adults often have protein intakes below 1 gram per kilogram body weight per day, predisposing them to the loss of lean muscle mass. So it was actually very timely that a week ago, when we attended the Fragility Fracture Network Global Congress in Melbourne, one of the most impactful lectures that week was by nutritionist Sandra Giuliano. So they released the results of a large 2-year cluster randomized trial involving more than 7,000 patients in 60 aged care homes, simply to answer this question: can improved nutrition using high calcium, high protein dairy foods actually reduce falls and fracture risk in older adults in aged care? The results are resounding yes. So dairy supplementation achieving 3 servings daily in older adults with inadequate calcium and protein intakes was associated with a relative risk reduction of 46% for your hip fractures, 33% for all fractures, and even 11% for falls. So they show that this slowed bone loss, increased growth factors, and maintained both weight and nutritional status. Their dairy food serving was defined as 250 ml of milk, 200 grams of yogurt, and 40 grams for cheese. So again, we have to emphasize the benefits of a simple nutritional supplementation in these patients. So now we go to pharmacologic treatment. We won't really talk about SERMs or your selective estrogen receptor modulators, as this is not recommended for your orthogeriatric patients because they don't really fit the patient characteristics that are appropriate for these drugs. So we'll go quickly to bisphosphonates. This drug binds the bone and it's incorporated into the bone matrix, where they exert their action primarily by inhibiting your osteoclast-mediated bone resorption. So it does this mainly by disrupting the ruffle border formation, as seen here, leading to apoptosis. Contraindications for all the types of bisphosphonates are hypersensitivity and hypocalcemia. Zoledronic acid should not be used in patients with impaired renal function. You have to avoid your oral bisphosphonates in patients with esophageal abnormalities that delay emptying time. Also try to avoid this drug in patients who have the inability to remain upright. Adverse effects include your upper GI reactions for the oral bisphosphonates, acute phase reactions like fever, malaise, eager bone pains with your IV form. There's also been a documentation of atypical femoral fractures and your osteonecrosis of the jaw, but both have been very rare, with osteonecrosis of the jaw being seen in 1 to 100,000 patients. So while doing this lecture, actually, I came across a very useful published article by local endocrinologists in the country, where they developed a visual aid for patients in helping decide the appropriate anti-osteoporotic medication across different types of bisphosphonates and other drugs. So they provide a good summary of your drug efficacy, side effect, and even costs. So you can access this article online for free. So now we go to anabolic drugs. They're recommended in postmenopausal women who are at very high risk for fracture, such as those with severe or multiple fractures. So your teriparatide is a parathyroid hormone receptor agonist, while the abaloparatide, it's also very similar. It's a PTH-related protein analog. And your romosozumab, which is an anti-sclerostin antibody, are all anabolic drugs. While teriparatide is a current therapy, the other two drugs are considered emerging therapies, although romosozumab has already been used in Japan since 2019, I believe. However, when it comes to your PTHR agonist, we don't have enough evidence for hip fracture risk reduction, and their safety and efficacy have not been established beyond 2 years of treatment. So the maximum duration is usually 24 months for this type of drug. So let's go now to denosumab. It's a human monoclonal antibody that specifically targets your rank ligand, an essential mediator of osteoclast formation, function, and survival. So when it prevents your rank ligand rank interaction, it inhibits the osteoclast formation, function, and survival. Therefore, your bone resorption is decreased, and you can increase the bone mass and strength in both cortical and trabecular bone with this drug. So it's best to consider this in patients with renal impairment, those with an intolerance or failed bisphosphonate therapy, and those with difficulty in dosing or non-compliance with your oral bisphosphonates. Contraindications, again, include your hypocalcemia and as well as your vitamin D deficiency. So you have to correct for those factors before even considering such type of drug. So there's a robust evidence supporting denosumab safety, efficacy, and compliance. Okay, well, let's go to safety. So the FREEDOM study comparing denosumab with placebo is a large international multi-center randomized controlled trial. Their initial study duration was 36 months. However, they extended this to up to 10 years and enrolled 4,550 patients just to look at the safety and efficacy of the drug. So I know this is a busy slide, but just to show you the comparison in terms of safety outcomes between your placebo group in the first 3 years and your combined denosumab groups. When we say combined, we mean those that took just the denosumab and those that crossed over from the placebo group. So you can see here that the yearly exposure-adjusted incidence for all adverse events, which is the first row there in the table, was low and stable throughout the 10 years. Yearly incidence for adverse events of interest, which includes your hypocalcemia, your osteonecrosis of the jaw, and a typical femoral fracture, remained also similar throughout the extension and at rates that are very low, almost less than 0.1 per 100 patient years. So basically, denosumab treatment for up to 10 years was associated with low rates of your adverse events. In terms of efficacy, there have been 4 large head-to-head RCTs where they compared denosumab with different kinds of your bisphosphonates. And it's shown that denosumab consistently shows significantly greater gains in bone mineral density than your bisphosphonates. The STAND trial also looked for and showed the efficacy of transitioning to denosumab from your alendronate. So the results showed significantly greater bone mineral density gains in favor of transitioning to denosumab versus continuing your alendronate, regardless of the duration of the prior alendronate treatment. But it's not just about observing your bone mineral density increase. More importantly, clinically, there is a sustained low fracture rate among denosumab group as seen in the previously mentioned FREEDOM trial. How about compliance? So the DAP study, denosumab adherence preference satisfaction, analyzed more than 100 patients in each group, so denosumab versus alendronate, and then they looked at non-adherence to the treatment. So this is the result. You can see in the blue bar, that's your denosumab group, and the yellow is your alendronate group. So with 2 years worth of follow-up, results showed that non-adherence, non-compliance, and non-persistence were significantly less of a problem with your denosumab group compared to your weekly oral alendronate. And that they did report as well greater satisfaction with an injectable denosumab over an oral alendronate. So now when assessing response to any anti-osteoporotic therapy, you have to get your serial BMD measurements. You can repeat that in 1 to 2 years of doing your therapy. If it's shown to be stable or improving, then you can continue treatment as this is considered a positive treatment response. If it's a negative trend, then you have to assess first your non-compliance, your calcium vitamin D intake, and you have to rule out other causes of osteoporosis before considering your alternative drugs. When is the treatment considered enough? There's really no universal agreement, especially after 10 years of treatment. You still have to base it on your calculated risk for major fractures for each patient. So that's based on your crack score, which I'm sure some of you are familiar with. When you have a hip fracture risk of more than 3% or a major fracture risk occurring more than 20%, then it's still important to be giving your therapy. An important technical remark here with denosumab is that its administration should not be delayed or stopped without planning for a subsequent anti-resorptive therapy. That's to prevent a rebound in bone turnover, which they've seen happen, especially in your vertebral BMD. But whatever BMD gains that is lost with the rebound effect can be restored with your retreatment. So that's it for my talk. Thank you very much.
Thank you, Carla. Thank you, Carla, for that very interesting presentation. I think one of the take-home messages here is the non-pharmacological aspect as well of preventing osteoporosis. I think you've really conveyed the information that we've learned in the Fragility Fracture Network Global Congress, and thank you for emphasizing that. Okay. So Carla is one of our champions in the Western Visayan region in promoting our hip fracture registry. And although her first love is tumor, her second love is fragility fractures. So thank you, Carla. So with that, maybe we can have a working snap, and we would like also to acknowledge the presence of the Assistant Director for Hospital Operations, no, who will be giving a message as well on behalf of the Philippine General Hospital administrative staff. May we call on Dr. Stella Jose, no? As you all know, since the inception of the Orthogeriatric Multidisciplinary Team and Fracture Liaison Service, the hospital has been very supportive, no, for us to carry out this program, and it has benefited many patients, no, including our own relatives, no, my own relative and relatives of staff here in the Philippine General Hospital. Without this pathway of care, I don't think we can prioritize patients with hip fractures, and for that, we would really thank. We would like to thank the support of the hospital of Philippine General Hospital.
Good afternoon, everyone. I'm glad that I attended this lecture by Carla. You know, I'm on denosumab. So I'm already 64 years old. So, but before that, I was on bisphosphonates. Okay, so tama siya. Ang problema sa bisphosphonates, you have to drink it on an empty stomach. And then you have to do walking exercises for 30 minutes to an hour before you can eat. No? So talagang nakaka-hyperacidity siya. Tsaka nakakalimutan ko. So I started with Bonviva, ibandronic acid. Then it was spaced out, and then I'm on alendronate once a week, which is cheaper than Bonviva. No? Pero talaga mas magaling yung denosumab kasi once in 6 months yung injection. Kaya lang, it costs 12,000. Okay, 12,000 for one injection, but you have to do it twice a year. So anyway, with senior citizen, it became 9,000. So anyway, I'm glad that I attended this. So parang it cemented in my mind the need for pharmacotherapeutic meds for patients who are menopause. No? So in OB, we routinely do that, yung bone scan, bone mineral density. So pagka 60 and above. And then, pero ngayon, sabi, ang alam ko kasi every 3 years, sabi ni Carla, every 1 to 2 years. So papalitan na natin yan. Okay, sundin na natin yung sinasabi niya. Okay, so it's very encouraging that there are so many attendees to this symposium. Ano ba to? Mandatory ba kasi siya? Hindi naman, di ba? Talagang gusto nila mag-attend, di ba? Gusto nila, yan, tama yan. Yun ang attitude. Anyway, masarap yung food na sa labas. No? Pero I'd like to congratulate the Department of Orthopedics. You know, orthopedics was one of the departments that I wanted to go into when I was an intern. But I assisted an OR of a femoral neck fracture, and the resident told me to carry the leg of the patient, and then I had to abduct and adduct. After that, ayoko na mag-ortho. Talagang sabi ko, di yata to para sa akin. So I went into OB. Pero the thing is, we need more orthopedic surgeons in our country. Believe it or not, yung mga interns na nandyan, kung mag-ortho kayo, kasi it's a very good way to practice medicine and you help many people. Magpunta lang kayo sa ER, ang dami nating patients na fracture na kailangan. So palaging may request si Aning na Stella, dapat mag-limit kami ng admissions kasi hindi namin kaya, our list is very long. So pag sinabi ni Aning yun, syempre I just agree with him. Tapos mamaya pagka natapos na yung pag-stop ng admission, ang dami na naman. So it's like a never ending, para siyang waterfall, hindi na uubos yung tubig. Ganun din dito, yung patients na kailangan ng orthopedic surgeon, hindi siya nauubos. No? So when you go out in private practice, ganun din siya. Okay? So the people, our countrymen would really appreciate going to an orthopedic surgeon. So just go on with what you're doing. Andyan pala, saan si Aning? Nasa office niya. Oh, anyway, sabihin niyo dumating ako. Ayan. Anyway, sige. Thank you very much for your attention.
Thank you, Dr. Stella. Salamat po. Salamat. Again, we'd like to thank our partners, industry partners, Amgen Zuilig, no, for the great the food, no. Sabi masarap daw, no. Sayang di ako nakakain dyan. Pero I would like to thank them for supporting our World Osteoporosis Day activity. Okay, as well as Fonterra, the makers of Anlin. Okay, so maybe with that we can move on. No, while you are getting your food, no, in 2 minutes we can settle down and we can proceed with our next set of lectures, including the plenary. I mean the panel discussion, no, and the mini workshop that we want to offer to those hospitals and institutions, no, who want to start an orthogeriatric or fracture liaison service. So what I will present later is the basic steps, those things that I got from the 5-year experience, in navigating the orthogeriatric and fracture liaison service of our hospital, including the COVID period. So yeah, so in 3 minutes maybe we can settle down so that we can introduce our next speaker. Hey, good. Sorry. Good afternoon, everybody. I hope you enjoyed your snack. So before we proceed with the lecture, we just like to acknowledge the presence of the different departments from the Philippine General Hospital who's been instrumental for the formation of the orthogeriatric and fracture liaison service of the UPPGH. Without them, actually, if we only orthopedic surgeons would be the advocate of this, the program will not work. And this is actually one model that we want to spread out to the other institutions, who are also listening and participating in today's activity. With this, it's been a good 5 years. There's been lots of ups and downs, especially with the pandemic. We were really challenged. With the pandemic, the PGH being designated as the first COVID referral center. So, but with the perseverance and the help of the other departments, we were able to carry out our obligation to serve not only those patients with COVID, but also to continue our service to the elderly patients with hip fractures, many of which had also COVID, were brought to the hospital. So Vince, Dr. Garduse, can we please acknowledge the presence of the 4 other departments who are really a big part of the orthogeriatric fracture liaison service team? Again, as I've mentioned, without the teamwork that we continue to exhibit, this advocacy or this service will not push through. Okay, Dr. Garduse, Vince.
Again, we would like to thank our partner departments for in our efforts to take care of our orthogeriatric patients. So we have Dr. Epino from Department of Anesthesiology, and we also have and we also have Dr. Dothy of Rehab Medicine. Thank you, ma'am. Okay, along with us today is representatives from endocrinology, sir. Afternoon. And family medicine and internal medicine as well. Thank you, ma'am. Afternoon po.
So we have a simple certificate of recognition, Vince, di ba? I hope you can give them to the department so that they can show it to their respective staff as well.
Yes, sir. We'll give the certificates of recognition po in a while po. Thank you.
Thank you. We'd also request for from our colleagues to stay for because in the next 20 minutes we'll be having a short panel discussion, an index patient that we are taking care of, was a fragility fracture with COVID patient, with COVID, and then we will have a small group discussion or panel discussion, no, about this case, no, following the lecture or the presentation that we will be having next. So maybe if everybody has settled down, I can introduce the next lecturer. Pwede na ba?
Yes, sir.
Okay. So as you all know, fragility fractures are not only hip fractures. No, if you listen to the presentation of Professor Mitchell, no, hip fractures are just the tip of the pyramid. But next, there are other fragility fractures. And actually, the most common fragility fracture are vertebral fractures. In fact, if you want to prevent hip fractures and if you want to stop osteoporosis, at the initial phase, maybe catching the vertebral fracture is the most important thing to do. No? So at this point, we will pivot or we will highlight the other fragility fractures. No? So the next presenter is also a clinical associate professor of the UPBGH Department of Orthopedics. She's also an osteoporosis advocate. She's a member of the spine division, and she's part of the POA evidence review experts group, no, for the osteoporosis clinical practice guideline that's being developed by the Osteoporosis Society of the Philippines. No, so with that, I would like to introduce Dr. Mary Ruth Padua to give us a lecture about fragility fractures. Ruthie.
Arwin, thanks for that kind introduction. So I really appreciate putting this forward. No? So because actually, as Irene have said, fragility fractures of the spine are more common than hip fractures. But I think mas popular or mas mas familiar tayo with hip fractures. So I think this would be a start for us to be able to orient ourselves again on how to screen, manage, what's the current management for spine fractures, osteoporotic spine fractures, and how to treat them. No? So I have no disclosures for this lecture. So why are osteoporotic compression fractures also a priority? So the decreased physical activity due to pain may cause the following complications, which is also similar with your hip fractures. You have your deep vein thrombosis, acute myocardial infarction, pulmonary embolism, stroke, and pneumonia. So the difference is for hip fractures, we're aiming for early surgery, right? That's 48 hours. That's the recommendation based on the NICE guidelines as well as the SIGN guidelines. But it's different for osteoporotic fractures. We don't have that timeline. However, it's more of the treatment of these patients are individualized. So it depends on the symptoms of the patient. So for outline, how to screen for osteoporotic, mainly for osteoporosis, we'll be reviewing about the risk factors. What are the current scoring systems that we can use that would indicate us or point us to do a DEXA scan? Surgical management, we are already familiar with this. That would be your kyphoplasty, vertebroplasty, or does still conservative management have a role in the treatment of these fractures, as well as pharmacologic treatment specifically for your vertebral fractures. So let's review, no? There are non-modifiable risk factors that we are very familiar with. That would be the age of the patient, more than 65 for females, and males more than 75. We already know that in females, it's more common than males, but we are actually getting more familiar with male patients who have also osteoporosis. One more important factor would be a previous fracture. That would be distal radius or a spine fracture or a hip fracture. Parental history of an osteoporotic fracture and early menopause for those patients who have other pathologies, other gynecologic pathologies that would necessitate early surgery or TABISO. Other modifiable risk factors would be your low BMI. So actually, a little bit on the heavy side would be an advantage. So also smoking, low BMD, as well as alcohol intake. For coexisting diseases, sometimes we stop with the screening for the modifiable and non-modifiable factors, no? But we have to review for each patient, do they have diabetes, RA, SLE, HIV, no? Endocrine disorders, chronic liver disease, Parkinson's, asthma, or are they under specific drugs like antidepressants, anti-epileptics, PPI, glucocorticoids, or anti-diabetic agents, which we call TZDs. So those drugs increase the chance of osteoporosis also. So how would you quantify the risk? We are so familiar with FRAX already, but in the recent guidelines, no, based on SIGN as well as NICE, they are using already the Q fracture. Why is that? Because they are already including all the other diseases that we might miss. So that would include the parental history of fracture, if the patient has RA, the antidepressants, the neurologic disorders. So this would be more useful for us if, for example, FRAX, no, I think every country has its own version of this. Q fracture, of course, mas familiar siya pagka because it's based on UK population. So screening for DEXA scan. So why Q fracture? Wider range. It's based on 30, as early as 30 years old to 99 years old. And it includes ethnic groups, which is not seen in FRAX. Different groups, including the elderly, no, from the younger ones to older ones, and varying time frames, and the transparency of the study when they conducted the validation of this scoring system. So the fracture risk threshold of 10% is to indicate the need for DXA. So you have to actually do first FRAX or Q fracture, and then see if the risk is around 10%, and that's when you do your DEXA scan. Okay, sometimes we do it automatically, no, 50 years old, that's also a recommendation. But if, for example, in our setting, not all our patients can afford DEXA scan, that's a way to do it also. So the indication that treatment significantly reduces the risk of fracture in patients with a fracture risk in the region of 10%, that's why they choose 10%. So that's the cutoff before you request for a DEXA scan. So going into management, no, vertebroplasty is when you put a tube within the vertebral body through the pedicles and then insert a bone cement to stabilize the bone temporarily while the bone is healing from the fracture. So there are lots of studies already based on the randomized control trials, and current CPG guidelines indicate that when they review the systematic review comparing vertebroplasty versus standard care, which is no surgery, there's actually a difference, no? But for vertebroplasty, it's just limited to early. So that would be the first day until day 14. So it's, by common sense, it's not actually very practical based on those studies. Another one would be, no, other systematic reviews say otherwise. So it's prolonged, the improvement is prolonged, 12 months, 24 months, even up to 36 months. But it attenuates the differences between the conservative as compared to the vertebroplasty, no, minimized na siya, nagiging hindi na significant as compared dun sa early results nila. The ODI, however, when they measured it, it's better with vertebroplasty compared to conservative management. Also, the quality of life scores for these patients is better at 1 month and 1 year. However, beyond that, there's no significant difference anymore. How about vertebroplasty and kyphoplasty? So, sikat tong kyphoplasty, no? Explain ng doktor, lalagyan ng balloon sa loob, and then the cemento, i-lift daw yung bone, no? It really has its role, no? But when you compare vertebroplasty and kyphoplasty, no significant difference again, based on clinical practice guidelines. So the range of these studies, no, it's around mga 2009 to 2014. So yun yung results nun. the complications will be less for vertebroplasty versus kyphoplasty. However, the role of kyphoplasty is it prevents new level vertebral fracture. So because of the propping up of the bone, no, it prevents another vertebral fracture or subsequent fracture. O sige, kyphoplasty naman in standard care. No, when they compared it again, conservative management, that is pain medication, bracing versus kyphoplasty, no significant difference again. So this is a bit discouraging, no? The pain outcome scores compared at 6 months started to diminish, no, even after 12 months. So early lang yung improvement, and then later on it's already the same. The quality of life is also the same results. So early there's improvement, significant improvement comparing kyphoplasty versus conservative management, and then it diminishes. No, it attenuates. Okay, the complications obviously, of course, it's greater in kyphoplasty because it's a procedure. You don't have any complications or minimal complications with conservative management. So based on this, in that time range, no, there is no sufficient evidence when comparing kyphoplasty versus conservative management. However, in recent studies, that is in the past 4 years, starting 2019, they've been releasing network meta-analysis comparing which ones of the procedure would be the most advantageous for our patients. So this is kyphoplasty versus vertebroplasty and standard care. Okay, so the population is the same. The comparisons between the three procedures, no, or treatment options, and then what they found out was vertebroplasty actually is most effective for pain, ODI, quality of life, and EQ5D. No, and then they also have the specific results for your balloon kyphoplasty. So it also it also improves the quality of life and reduces the risk of subsequent vertebral fractures. And then for non-surgical treatment, you're just preventing actually a subsequent fracture. But the pain, it's actually better if you have the procedure. Now, how about another study, no? This one is again a network meta-analysis, and it boils down to vertebral augmentation is better than conservative. So you can see the pendulum moving. No? 10 years ago, no significant difference. Now they're pointing towards intervention. So because the quality of studies actually are better now, no, as compared to before, because those are just randomized control studies, and the methodology as well as the selection of the patients were a bit biased. So now they fix those design problems, and these are the results. So balloon kyphoplasty is the first option in alleviating pain for short term. No, PVP is also the advantageous for acute, subacute osteoporotic vertebral compression fractures for the short term. And you have another player, no? You have your nerve blocks. So if the patient doesn't want any implant, no balloon kyphoplasty, you can do your nerve blocks initially. Then if it doesn't work, you can offer your patient vertebral augmentation. So those are the recent results. How about for pharmacologic therapy? You have your pamidronate, no? But the results of this, they have a lot of problems with the study design, but they noted that there is improvement actually with pamidronate versus placebo. For calcitonin, it's the same. But however, the trials are generally small, and there's poor quality as well as information on the methods of recruitment and randomization. So also the meta-analysis showed that there's significant heterogeneity in the population chosen. What else? For teriparatide, almost this is also highly recommended. For acute fractures, the VAS scores, when they compared risedronate and teriparatide, There's at 18 months, there's 69.3% as well as 72.2% improvement in 30% of patients. For chronic, slightly less in teriparatide group, but this is only based on an RCT study. Okay, so based on those 3 studies, one is a meta-analysis, 2 are RCTs. The conclusion is also insufficient. Okay, we see the results, we see the improvement, but there are study flaws, no, that we cannot really recommend these drugs for in the treatment for painful vertebral fractures. So we have to wait for those better designed studies. What else? How about combining vertebroplasty and zoledronic acid? So this one, they compared vertebroplasty and just doing plus zoledronic acid versus just vertebroplasty. So again, this is a meta-analysis based on 4 randomized studies and 4 retrospective studies, and have shown that combined with zoledronic acid, it was superior to vertebroplasty alone in terms of bone density, as well as pain and improved function. Okay, it's a busy slide, I understand. So, but the pharmacologic therapy for osteoporotic vertebral compression fractures in this diagram is separated in primary prevention and then secondary prevention. This is mainly a recommendation also for your postmenopausal osteoporosis, and other populations are not included in this recommendation. Back in 2017, oral bisphosphonates at 10-year fracture risk of 1% was recommended. IV bisphosphonates was recommended if you have a risk of 10%. So treatment significantly reduces the risk of fracture in patients with a risk in the region of 10% or greater. So if you have already a fracture, it's understood you're beyond that 10%. So I simplified that diagram. As you can see here, you have a spine fracture, and because you have a spine fracture, you can request actually for an automatic DEXA scan. But as Dr. Araneta said before, it's not actually necessary. If you have a fracture already, you can actually start treatment directly. So if you have severe osteoporosis, okay, and then it's high risk for other fractures, you can use actually teriparatide and then observe for the next 5 years now and adjust that later on. We don't have the second drug yet here in the Philippines. No, it's still an emerging drug. And then for those patients with not severe osteoporosis, as defined before in the lecture before, you can actually give the patient alendronate and risedronate. Depending if the patient has any adverse effects or poor response, or the patient prefers another drug, you can continue that for the next 5 years and review. Okay, so I guess there's some discrepancy though, that the others would recommend 3 years, 2 years, but here they're recommending you continue with the medication for at least 5 years and then review. And then afterwards, if the patient has any adverse effects, you can actually choose another medication that would be your parenteral bisphosphonate. If the patient prefers otherwise, you can give denosumab and again, give that medication for the next 5 years and review. Or if not, you can have zoledronic acid instead. Give 3 infusions and review after 5 years. So to summarize, we have identified actually the risk factors, the use of fracs, key fracture, as well as the indication for doing a DEXA scan. Having a spine fracture, hip fracture, or wrist fracture is not actually, you're not indicated anymore to do a DEXA scan. You can go straight to treatment. And then surgical management, vertebral augmentation is better in conservative management in recent studies. And vertebroplasty is better than kyphoplasty for controlling pain. For preventing adjacent or subsequent fractures, you can do your kyphoplasty, and it's better than vertebroplasty. However, if the patient opts for no cement augmentation, you can do your nerve block, and then later on, if it doesn't work, you can do your vertebral augmentation. Pharmacologic treatment, so they say in terms of pain control, there is still insufficient evidence. However, combined treatments such as vertebral augmentation in combination with medical management will always be better than just medical management alone. So thank you. That's all po.
Thank you, Ruth, no, for that very informative lecture. Actually, I want to ask Ruthie, no, in your subset of patients, no, those that you see in your clinic, what percentage, parang sa real world setting, no, what percentage are you able to do surgical management? And what percentage are being parang offered conservative, quote unquote, conservative management?
Honestly, if, for example, you have 10 patients with osteoporotic fractures of the spine, maybe just 2 would proceed with surgical management.
So, yun, no?
Actually, if you give teriparatide early on, and even without bracing, they would actually be better after a month or so.
Okay. I think that's very enlightening.
If it's cultural, because you just give, it's not, the pain relievers are not even high.
Mhm.
You give them maybe 3 weeks of tramadol or Dolcet, and then when they come back, they're already happy. They're
Okay.
wala ng pain because of the teriparatide. So yun.
We have a
And-
question.
And
Ano?
honestly, kyphoplasty doesn't have, it's not without complications.
Yes.
Then the patients are also expecting it's like magic. It's not, because the other segments of the spine are still osteoporotic. So you still have to give the anti-osteoporotic medications after the surgery.
Okay. So we have a question, no, from our online audience. Can denosumab be the first line drug in lieu of oral bisphosphonates, since recent studies show no plateau as opposed to bisphosphonates? I know you've been reviewing the literature, Ruthie, in the CPG guidelines that we are doing.
CPG guidelines, wait. For the, actually you can do straight denosumab, pero yung straight, ito kasi yung multiple drug comparisons, actually you can go straight to denosumab. And there are new studies emerging comparing teriparatide and denosumab. Kaya
Okay.
that's isa pa lang yun. Isang study pa lang yun.
Okay. Are there any other questions dyan sa live audience? If none, thank you, Ruthie, no? But please stay, because I want you to be part of the next segment, which is the panel discussion, no? Just no, sasama kasi natin yung vertebral fractures. So at this point, may we call on yung our representatives from the different departments. I think we have Dr. Gia Limpoco and Dr. PJ Francisco from the Department of Family Medicine, Dr. Doty from Rehab. I think they're fellows or residents from anesthesia as well, and the chief fellows from Endo and CVS. So Vince, can you facilitate, as I will be sharing my slide again, no, for the next part. This is the, for the students, this is the real world scenario that you will see when you go out from PGH or at the emergency room, no? That's why we want to after the theoretical presentations, we always want to show some cases. Okay. I just show. And this will be very helpful as well to the other hospitals who wants to establish an orthogeriatric or fracture liaison service, no? Especially those included in our recent multi-center study. Okay. So this is the same patient that we presented last year, no, in our World Osteoporosis Day celebration as well. Again, and we're there are always patients presenting at the in the hospital. So it seems that we have to live with the COVID virus. So elderly patients are still presenting with hip fractures with concomitant COVID conditions. So this is a 78-year-old female home ambulator, fell from a standing height. Okay, she has uncontrolled diabetes with severe osteoarthritis of both knees. Okay, she's taking no meds for bone protection, and she was admitted at the hospital 2 days post injury. Okay, unfortunately, she was found to be COVID positive, and but with O2 sats ranging from 94 to 96% at admission. She also was found to have pneumonia with consolidation, and these are her ECG findings. Okay, these are her chest X-ray. Okay, and of course, she's in terrible pain, undescribable pain. No, some patients would describe hip fracture pain as more than dying. Okay, ganun kasakit yung hip fracture. They cannot move, they cannot urinate well, they cannot even turn to their side. Okay. So what's the dilemma when we manage this particular patient? Do we proceed or do we delay the surgery given that the patient is COVID positive with signs of pneumonia, both clinically and on chest X-ray? Do we offer conservative management instead? No, and hearing from the lectures earlier that the gold standard for patients with hip fractures is to do immediate surgery, ideally within 48 hours, no, to alleviate pain and to prevent the progression of complications such as bed sore, urinary tract infection, no, and peptic ulcer disease. So how will you explain the prognosis to the relative? No, parang it's difficult to push for the surgery given that she has COVID and she has pneumonia, no? But if surgery will proceed, what's the best type of anesthesia and what type of surgery from the standpoint of the orthopedic surgeon or the anesthesiologist? And then how will you give the rehab regimen, considering that maybe post-op, she will still be isolated? Because normally, if these patients will be isolated for at least 5 days nowadays. Before, it was even longer. What about secondary fracture prevention? What bone protection or anti-osteoporosis medication can you give to the patient? And how can refracture be prevented? Okay. At this point, I will stop my screen sharing, and can we ask our maybe first our colleagues from endo or from the internal medicine, no? How can we endo and CVS, no, with under the realms of the multidisciplinary orthogeriatric care within the realms, how can we provide or manage this patient, no, acutely, given that she has a hip fracture?
Hi, sir. Good afternoon. This is Archie Apaapo from
Hey,
Endocrinology.
Archie.
I'm representing Dr. Mark Sandoval po in his behalf. So for our patient, no, it seems that the patient had multiple comorbidities. She had uncontrolled diabetes and is currently presenting, no, with pneumonia on top of her hip fracture. So we agree that the patient really needs the immediate surgery, but we also need to control the diabetes first with the insulin therapy, and we also need to address the patient's pneumonia with antibiotics. So this is the time that we really need a multidisciplinary conference, no, to be so we can decide the proper management to be given with the patient. So we need the cardiovascular service, the pulmonary service, as well as the infectious disease.
Thank you, Archie. No, from the cardio standpoint, we have I think our fellow from CVS. Do we automatically need 2D echo for this patient? Or maybe we can just ask Archie again, no, from point of view of the internal medicine.
Hi, Arwin. Donnie here from
Donnie, sir.
Cardio.
Yes, Donnie.
Hello. Hi.
Yes, from Singapore.
Good afternoon. My comments were not necessarily represent those of the division, but siguro yung aking input dito is question of delaying the surgery, no? I think ang role ng cardio dito is not to delay the surgery, but rather to assist and to allay any fears. If there is any emergent nature of the surgery, that will be one factor to go ahead with the procedure. Second, if there's presence of any acute cardiac event. And thirdly, if there's elevated cardiovascular risk. So those 3 E's will help the ortho team decide how aggressive we will be in pushing for the surgery. As far as your question on echo, remember that the resting echo is not really that accurate in picking up presence of CAD or ischemic heart disease. So I think you go clinical. And if there is any indication to do an echo, it would be the presence of an acute cardiac event or elevated cardiovascular risk. I hope that answers your question, Arwin.
Thank you, Donnie. I would just like to introduce Dr. Jose Donato Magno, no, to the group, to the interns, no. As he mentioned, no, his views may not really reflect, no, yung current views of, you know, the cardio service in PGH or, but Dr. Magno is a very progressive and open-minded cardiologist who is a pioneer part of our orthogeriatric FLS team, no? Because in our country, in most low to middle income countries, we cannot do away with the cardiologists, no? They are like the gods in giving risk stratification for patients. We always, most hospitals or most orthopedic surgeons would defer to cardiologists, no, to give the risk classification for patients. So it's what has being done in the developed countries is really not applicable at this point in time, no, in our country, wherein they just let the geriatricians, no, give the risk stratification. So it's very important for us to engage our colleagues from cardiology, and it's a good thing that we have you know, an advocate within the cardio service, Dr. Donnie Magno, no, who's willing to at least support, no, the multidisciplinary management of patients, elderly patients with hip fractures, and especially now, and more patients are being infected with the COVID virus, even asymptomatic, no. So Donnie is very receptive. And another very important issue, most of these patients are on prolonged intake of aspirin, even clopidogrel, cilostazol, blood thinners. So how can we, Donnie, no, I want the, you know, our audience to hear, how can we manage this patient? How can we deliver the so-called acute care if these patients are in these you know, blood thinners, given that the general notion is to delay up to 7 days if they are taking
Oh yeah, that's a great question. Maybe before I answer that, I'd like to quickly comment on what you said earlier. Actually, CV risk stratification is not the monopoly of cardios, you know. I feel it's a primary competency even of the primary care provider. And if the general physician wants assistance from the cardio, by all means, you can always call on us. Now, as far as antiplatelets, anticoagulants, that's a tricky issue because we're talking about elderly who are at greater risk of bleeding and they have other medical conditions that might elevate their bleeding risk as well. So I think you have to dialogue with your IM colleague as to whether the antiplatelet is really necessary in this patient. Sometimes they're just on the antiplatelets, but actually they're not compelling. So in that case, you can do away with those things. But if, let's say, this patient has really high thrombotic risk, then maybe your IM or cardio would lobby for shorter period of discontinuation or even try to maintain to some extent the antiplatelets, especially in patients maybe with stents or with extremely elevated risk for thrombotic events. So I think there's no hard and fast rule here. I think the bottom line is really dialogue with your colleagues from IM and cardio.
I think that's a very good insight, no. For this subset of patients, they have different comorbidities, no. There's really no one clear-cut pathway of care. We have to individualize our approach for elderly patients with hip fractures, no, depending on their comorbidities. No, just for the benefit of maybe the orthopedic surgeons or listening to us or the students, I've been practicing the principles of orthogeriatrics for the past 5 years, and hip fracture surgery at the hands of a competent orthopedic surgeon who knows how to do hip surgery is really not that bloody compared to other surgical procedures of the GS, maybe spine procedures. No, I'm just talking about hip fracture surgery and hip replacement or fixation of the hip. It's really not that bloody. As long as maybe you prepare blood, the hemoglobin is above 90, and you do the proper planes, no, the proper dissection. No, in the last 5 years of my practice, I never delayed a surgery for patients with hip fractures just because they are on aspirin or clopidogrel, silostazole. The longest that I've delayed was 3 days. The patient was on warfarin because she had a previous cardiac surgery, so she was maintained in warfarin. But I really did not wait for everything to normalize. No, as long as it was on a downward trend, the PT-PTT, I proceeded with the surgery, and the patient survived. No, thankfully, and she's up and about. No, in after 5 days. But of course, we need the help of everybody to monitor, because it's really not clear cut, quote unquote, risk benefit ratio. You really have to explain to the family as well. That's why we also have our family medicine colleagues here now in the panel, because I think their intervention is very important, especially in our culture. Okay. Sige. I'll just can we ask our family medicine colleagues, no? Because in our setting, I know Dr. Agia and Dr. PJ is there. It's seldom that we are able to offer immediate surgery, no, within 24 hours. No, even in the private setting, usually there's a delay of within 2 to 3 days. How do you think can we involve the family? No, how can we maximize the involvement of family physicians, even general practitioners in the provinces, no, where there are no specialists, no, in explaining to the patient, to the family, as regards to the importance of acute hip fracture management, no, and how can they deal with the patient after the surgery. Any insights from our colleagues from the family medicine, Gia or PJ?
Hi, sir. This is PJ. Sir, for any cases of illnesses, it's very important that we have to involve the family because of the illness trajectory that we need to address. In this case, if we will be having an MDT, an immediate family meeting is very important so that we can discuss the prognosis. Remember that in this type of situation, a shared decision making between the medical provider and the family should be in tune. And remember that we need to explain the prognosis, whether good or bad, so that we can lay out all the plans and options and enable the family and the patient to decide which is the best treatment for this patient.
Okay. Thank you, PJ. No. So moving on, for this patient, actually, a family meeting was consummated with the daughter of the patient, and even if the patient was diagnosed with moderate COVID, of course the uncontrolled DM was managed, within 24 to 48 hours. The patient was able to undergo an immediate partial hip replacement, at 2 days post admission. Optimization was done in the hospital within 48 hours. Okay, and then at 2 days post-op, our rehab colleagues were able to do immediate mobilization, and at 1 month with a dedicated 6 weeks with a dedicated home physiotherapy regimen, she was able to survive, and walk again. So I would just at this point I would like to ask our maybe Ma'am Dottie. I know it's very challenging to provide immediate mobilization therapy, especially for elderly patients with COVID infection, because they are isolated. In our experience, what are the ways, for us to help these patients, ma'am? how can we provide immediate mobilization, because it's very important to immediately mobilize the patient to prevent complications.
Hi, Sir Erwin. So luckily in our center, we do have our COVID rotation by our rehab residents as well as our therapists. So our physiotherapists or physical therapists, once we receive the referrals, there will be a pre-op conditioning care, rehab care, where it will include initial baseline exercises, bed level exercises, given that this patient is just acutely suffered a fracture. So the simple exercises can be already done, except that one that had a fracture. So we can initiate some very simple activities of the arms and the leg, the non-affected leg, bed level. And they are the patients are commonly visited by our therapist regularly. This is also another way to prepare the patient for the operative procedure. No? So we also do give a pre-op conditioning program for the patient. And then subsequently, post-operatively, we will have to initiate a day-by-day progression of the treatment of the regimen. So early on, of course, we would expect that there will be pain post-operatively. And so even then, we have to initiate some exercises where we will be assisting the patient first on moving the affected limb. And that will also include moving the rest of the other parts of the body until we will be able to sit him up or sit her up. As if the patient, say, for example, the pain is bearable or tolerated, then we could immediately sit up the patient. And then, of course, for patients who are very motivated, then probably even stand her up right away. So again, that will also depend on the morbid functional level of the patient, because if the patient is sedentary right from the start, so it's a little bit difficult for us to motivate the patient. But if the pain control is good and the functional level pre-op are relatively, they are ambulatory, community ambulator, so it will be easier for us to motivate the patient to sit them right away post-operatively. So we go by day progression and transition until such time that we will be able to stand using a walker, and before going home, and that should be our goal, to be out of bed. Thank you.
From experience, we really have to partner with our rehab colleagues. No, it's really difficult to just do the surgery and tell the patient to move or to even stand. We really have to partner with our rehab colleagues immediately in order to maximize the management for our patient, because immediate mobilization and the weight bearing is critical for the prevention of complications. And talking about pain, no, I know we have some anesthesia colleagues there. No, that is our anesthesia service at the department or the hospital. They're very proactive, no, in managing pain and providing the proper anesthesia for these patients. No, can we call on our anesthesia colleagues? No, what are the ways that we are implementing, or what are the procedures that we are giving to our patient to minimize pain, both perioperatively, pre-op, and post-op? No, I just want to ask the insights of our anesthesia colleagues.
Hi, Arwin. Kim
Kim,
here.
yes, Kim.
So I was just asked to attend in behalf of our division chief, Sir Orthopedic Anesthesia, Dr. Lon Mangubat. I'm also the division chief for pain medicine of the department. We have been working closely with each other, meaning all of the divisions: orthopedic, anesthesia, pain medicine, and regional anesthesia division. So we have like our pathway wherein when these patients are referred to us, we get evaluated by pain fellows, and that's why we ask, do we need to bridge analgesia? How long will it take for these patients before they have their surgery? Because if it's like around 2 to 3 days, we put in a catheter, a peripheral nerve block catheter for analgesia purposes initially. And then during the surgery itself, what happens is if the catheter was somehow placed too low, sometimes because it's painful for the patients to move, Now we just put the catheter kung saan yung pinaka-accessible, and this is pre-op. So it can be removed and the single shot fascia iliaca block can be done. That would suffice during the surgery. And if it's needed further, or if the patient in the family agrees, we put in another catheter for post-operative analgesia naman. So that's how it's done when it's purely a regional technique. Okay, but of course, we have to take into consideration yung consent. Some patients really do not want na matusukan sila, and that's one of the contraindications, refusal of the patient.
Thank you, Kim. No, I think one of the the reasons for the success of our multidisciplinary team, is the involvement of the anesthesia, the pain, the pain service, the regional anesthesia service. I think what they're doing here at the Philippine General Hospital is really an innovation. Applying peripheral nerve blocks, fascia iliaca block, both pre-op and post-op. And we are trying to document this because from the response of the patient, they're really very happy, especially post-op. It's easier to mobilize the patient. You even don't need to prolong the insertion of the catheter. For most of our patients, right after the surgery, we already removed the catheter, and it's very, very important for the patients. It really gives them relief after the surgery.
Yeah, and we're very glad as well that multiple divisions of the department are involved in this endeavor. And if I may also just add, it doesn't stop there for us with the Division of Pain Medicine. What happens is these patients are tagged and they are actually followed up in the chronic pain clinic. So in the pain clinic, whether it's by telemedicine, or we time them na if they have follow-up sa ortho, they are also they are scheduled na din sa pain clinic so that they don't have to come to the hospital twice for follow-up. So we're trying to make it really accessible, the service accessible for the patients and convenient also. And we also get to at least tag those who might have ongoing pain even after the surgery. And mostly these patients are those with pre-existing chronic pain of some other anatomical or some other part of the body. So it becomes like a whole, it becomes like a full circle service. And we're very happy to be able to help patients and provide that for patients. Thank you.
Thank you, Kim. I think there are some issues that were questions that were answered by Dr. Donnie Magno, regarding stratification and washout. So we will look into this. Thank you, Donnie, for answering. So for our patient, actually, with the multidisciplinary fracture liaison service team, with the help of family medicine, I think the family meeting was very important in counseling both the patient and the daughter as regards to the prognosis of the patient. Perioperative pain control is necessary. Fast decision making. So fast decision making is very important, and communication between all the doctors involved in the team and as well as the family is essential for the management of this patient. And it doesn't stop with that. We need secondary fracture prevention. And I think aside from what PJ mentioned earlier, explaining to the family, there's the importance of family involvement post-op. And I think one of the strengths in the Philippines is that we have a good family medicine centered approach for the continuity of care. So we really have to involve family medicine for secondary as well as primary prevention of fractures. So PJ or Gia, if you're there, can you comment on this? What are the programs being started maybe by family medicine to focus on secondary fracture prevention, to bridge the care for these patients as they go home to their families?
Good afternoon, everyone. I'm Dr. Limpoco. So I'm one of the consultants involved in the family health unit of the department. So in family medicine, we use the PFC matrix or the lens. So that's patient-centered, family-focused, community-oriented care. So I guess for these patients being referred to us, wala tayong problema in terms of the patient-centered care because it's multidisciplinary. So the work comes in for FM in terms of the family involvement. So we look initially at the family assessment, we look at the dynamics of the family, their resources available, and then we try to integrate that in terms of the management. The challenging part is the transitioning of our patient from hospital post-discharge back to the community. So I think that's where the work would come in talaga, because this is where secondary prevention and also screening of other family members would come in. So for this particular family, once they are referred to the service, the resident in charge screens the whole family as well. Post-op na po yun, so meaning at the outpatient setting na, once discharged, automatically enrolled at the family health unit, and they are being followed up as well. So I guess yun yung importante kasi we really need to get the family involved on this, particularly in the secondary prevention for our patients. Thank you.
Thank you, Gia. I think this is very important. No? Listening to the presentation of Professor Mitchell earlier, no, as we assess the pyramid, no, as we implement the pyramid approach, I think for the purposes, even for our interns, no, who rotate in the community, it's very important to work with the family physicians, no, in order to really narrow the gap, the knowledge gap, no, as regards to osteoporosis, the knowledge about fragility fractures, hip fractures, vertebral compression fractures. I think this is very important, and we're happy that we are really, we are involving in the family medicine department is really very much involved, no, in our multidisciplinary service. And hopefully, I know Dr. Limpoco is board of the Family Medicine Society of the Philippines. Maybe we can expand your involvement as regards to osteoporosis and bone health care, no, of elderly patients. Di ba, Gia? Pwedeng gawin. Pinag-uusapan natin. Okay, so just for the information of everybody, this is the pathway of care that we've been following. As mentioned, no, Dr. Carla was instrumental into doing this when she was a chief resident. No, we had the Health Operations Office of the Philippine General Hospital approved this bundle of care, no, centered on multidisciplinary management, no, with a pathway of care for these patients with hip fractures. We based it on approved guidelines, no, from developed countries at the start. So we've been implementing this even during the COVID pandemic. We tried to implement this pathway of care even in challenging settings. And now actually we've mapped our patients. No, we have at least, I think, 18 patients that we've mapped with hip fractures with concomitant COVID infection, no, that we managed during the pandemic period. And we're trying to add things to our pathway, no, as we go on. As I've mentioned, this is a working pathway. We have to adapt and we have to implement this based on our setting. Okay, so we can't just rely on the evidence being offered to us, no, by the developed countries. So I think with our experience, we can propose this algorithm to other hospitals, no, and we will be publishing this paper, no, as regards to, no, how we manage elderly patients with hip fractures with COVID-19 infection, no, in our setting. So usually for patients with asymptomatic, with mild or moderate COVID infection with no fever or not in sepsis, we still recommend surgery within 48 hours. But for those with severe or critical COVID conditions, those who are oxygen requiring with pneumonia and sepsis, or those who we admit who are already intubated. These are the patients that we need to do medical stabilization first. And for all subset of patients, family counseling is very important. We really have to discuss with the family. Shared decision making is very important. And if these patients, with severe and critical COVID conditions, if they become more medically stable, then that's the time we do surgery. But for those who have mild and even moderate COVID, I think there's a big big benefit to doing early surgery for these patients with hip fractures. Okay, so I would like to thank our panelists for giving their insights regarding this. And at this point, I would just like to give this what I call the 6 steps towards being a center of excellence. Those who want to start an orthogeriatrics or FLS orthogeriatric or FLS program in their respective hospitals. This is very practical. First, I've been always asked, how can we start an FLS program? How can we start an orthogeriatric program? The very first thing to do is really to bridge the knowledge gap. You have to create your team, a small core group or a steering committee, inside your hospital. You may be a group of 3 or group of 4. Ideally, it should be multi-specialty. I don't think only orthopedic surgeons. If only orthopedic surgeons are involved, you can create this multidisciplinary team. You have to include other subspecialties. As I've mentioned, rehab, family medicine, internal medicine. They're a very important part of the group. Second, we always forget this. We have to do an assessment of service availability and a readiness assessment. We have to look into the logistical support, the manpower, the facilities, and even the supplies of the hospital. And preferably, before we start, we can engage the administration of the hospital. Number 3, I think it's very important to set your goals, set realistic goals. As you can see, there's the pyramid. You can start your orthogeriatric or FLS program at any stage of the pyramid. So whether it be in hospital or outpatient setting, if you're logistically prepared, you can start at both. In our experience, we started at the top of the pyramid because we can only handle at first patients with hip fractures, but now we're trying to expand the program to include patients with vertebral fractures or distal third radius and other upper extremity fractures. Number 4, create a healthcare bundle or pathway of care that will guide you and will guide the team on how to handle the patients. The pathway of care is not there to not make you think. As I mentioned earlier, each patient is unique. So it's just there for us to be guided, so that we have a common goal on how to treat our patients. Okay, we should at least target for early surgery. Doesn't necessarily mean it's within 48 hours if the hospital cannot support that, but at least we aim for that. We aim for immediate mobilization. We aim for good pain control. We aim for prevention of complications such as delirium or pneumonia, and we aim for immediate secondary fracture prevention. And number 5, it's very important, as mentioned earlier in the talks, we need to have data. We need to map our patients. We need to generate data because it is important to check if what we are doing is right or applicable. Maybe we can, at first, we can copy what others are doing. Maybe after 6 months or 1 year, we have to look at our data. Are patients benefiting from what we are doing, diba? Both clinically, is it cost effective? So that's number 6. We need to reassess, we need to evaluate, and we need to improve our pathway of service delivery. And we must not forget, patient feedback is very important. Kailangan nating tanungin yung mga pasyente. And I think this is a part of the data gathering that we need to improve on. Okay. So with us today, I know we have some representatives from the 14 institutions are involved in this DOST funded project, no. As I've mentioned, this is a pilot fragility hip fracture registry program in the Philippines, and it's nice to note that we are the 19th country in the entire world trying to start a hip fracture registry. Maybe the first 10 is in well-developed countries, but in Southeast Asia, we are the first country, was trying to map their patients with fragility hip fractures. And our main goal is really to create centers of excellence for multidisciplinary orthogeriatric care in our country, and to expand orthogeriatric and FLS programs in the Philippines. No, for once, maybe at least in this regard, no, for osteoporosis and hip fractures, hindi naman tayo mahuli, no, with our other neighboring countries here in Southeast Asia. So all of you have who registered will be receiving this e-toolkit, no. This is what I call the orthogeriatric FLS basic e-toolkit. So in this we have the clinical policy toolkit and the policy toolkit of the Fragility Fracture Network, as well as the best practice framework of the International Osteoporosis Foundation. So it's free, downloadable. So we will send all these links, no, to the participants of this activity, both online and those who attended face-to-face. Just give your email address to Nika, especially for the representative of the hospitals. And maybe this can be a starting point, no, of discussion. No, we really have to read. We cannot just absorb what I am saying or what the other advocates are saying. We really have to educate ourselves, because that's the only way that we can bridge the knowledge gap. No, these are very easy read materials. Okay, so another very important thing that I would like you to promote, all of this information, links, no, even the links from other organizations, we are trying to place it in our website. No, you can just type www.ffnphil.org, and we will have a repository of all these learning materials, and we are even creating a provision wherein you can have a chance to ask us, a chat box there wherein we can answer or help you establish your own orthogeriatric and FLS service in your respective hospitals. And I think this is a very good a venue, for all of us, So if you can visit this, and it has also a link to the FFN Global website, when again you can join for free, and you can all have this amazing information materials, all those that were mentioned by Paul and by Elizabeth earlier. So at this point, I would like to open the floor for questions, from all the participants, even from the students. For the panel members, we have a bit of a time for a panel discussion on how we can improve and how we can push this advocacy moving forward.
Hello, sir. This is Dr. Canyasares from Vicente Soto, internal medicine and nuclear medicine consultant. I'm interested in your on this fracture osteoporosis, because just like you, my mom was recently being operated for laminectomy by one of our orthopedic surgeon in Vicente Soto, and we're planning to make like osteoporosis clinic in Vicente Soto. Is it possible, sir, we can visit your setup in BGH in the future, so that we can copy and innovate what you're doing there?
Oh yes, of course, Henry. We can do that, We can have an exchange of ideas. And one good thing, Vicente Soto is already included in the multidisciplinary pilot hip fracture registry project. So you can connect with the Dr. Baklig and the other champions in your hospital, and then we can really collaborate, on how we can involve NUCMED, NUCMED in your multidisciplinary team.
Yes, because we're gonna have our own DEXA machine. So probably by first quarter of January 2020, first quarter of 2023, it will be opening already. So we have our own rheumatologists and also endocrine consultants and ortho, and also I think geriatric. So we can create a team and a clinic specifically to cater for this kind of patients. So I just realized that how it's very expensive, especially the teriparatide. It will cost around 27,000 per injection, and you have to do it for the next 2 years. And there's another one, a teriparatide, I think a generic one that will cost around 18,000, but they don't have stocks as of now. So we buy the originator, the Forteo. But it's really difficult if there's no surveillance, because we will capture them, especially if they already have fracture. So my mother, I just realized that my mother has severe osteoporosis when she was operated, because my surgeon friend told me that brittle na gid yung bones. So that's how I realized I really need to have surveillance. So that's why we came up with the idea that maybe we can create a team, and that will take care not only for patients but also maybe the hospital employee of Vicente Soto. So that would be our advocacy. But we're in the very beginning stage to create. But we're planning to maybe go there and watch your setup.
Thank you,
Thank you,
sure.
sir.
Oh, we really need your help, no? It should be a team effort, no, for the entire country. One thing that I really like, with this advocacy, we really don't need those big innovations. We don't need big money. We just need to work as a team, collaboration, interdisciplinary care, and then we can really improve the way we manage and prevent fractures, no? Because yung concern talaga is our mothers, and in 10 to 15 years from now, tayo na. So if we don't have a system in place, we will all suffer, as mentioned. Now that we have time, we have to take
I just realized it. I mean, parang wala sa mind ko yan dati, but when I have my mother na pag-opera, we really need to do something about it. I think just like you, sir.
I just received a message from Dr. Limpoco, no? They have a family medicine training in Vicente Soto as well. So I really think Vicente Soto can be one of the centers of excellence in your region, di ba? Pagka na establish kayo, you will be the center that will be emulated by the other hospitals.
It's an APIC hospital kasi sobrang laki na. I think 3,000 employee, and then marami na pong subspecialty. So plus we have our own nuclear medicine facility. So we're just waiting for the license. So I think it's nice to start something new.
Thank you, Henry. Thank you. We'll work closely with you. Okay. So do we have any other questions? I know we have representatives from JBL. Dr. Manalastas brought his team from JBL. Another also included in our pilot hip fracture registry project. So may mga questions ba from the floor, Vince?
Yes, sir. Hi, sir. This is Archie po ulit, sir. Comment na lang siguro, sir, from endocrinology. We failed to mention lang kanina that as endocrinologists, it's important also to screen for secondary causes of osteoporosis, such as your hyperthyroidism, hyperparathyroidism, glucocorticoid deficiency or excess, as well as glucocorticoid deficiency and growth hormone excess or deficiency as well, sir. Then renal problems should be also screened for the patient. The CKD of the patient can alter the management in terms of pharmacologic management when what we could give the patient post-operatively, either a bisphosphonate if the estimated glomerular filtration rate is more than 30, we could give bisphosphonate either oral or intravenously. But if it's less than 30, then we could give a denosumab as well. Then monitoring as outpatient is very important for us. So it's important really to screen patients who are at risk for osteoporosis as well as fracture. So Dr. Padua has also mentioned the modifiable, the risk factors, age, more than 65. It's also important to screen post-menopausal women as well as men. Nakakalimutan din minsan na men could also get osteoporosis as well. So I think that's it for endocrinology.
Yeah, yung yeah, I'd like to thank Archie for bringing this up as part of the team. We sometimes for patients with severe osteoporosis, ngayon there's already the term severe osteoporosis. We really need to tap the intervention of subspecialists like endocrinologists to really monitor their condition. Sobrang lambot-lambot ng mga pasyente na to, and I agree that we should refer to those subspecialties who will be able to take care of these patients, specifically managing their severe osteoporosis, quote unquote, to know the other causes for the disease. So thank you, Archie. Salamat. So you have other questions or comments from the participants? One reason that I want this dialogue kasi nga I want to we want to promote this hopefully in the next 2 to 3 years, really to have a good campaign with a strategy, hopefully in the next 2 to 3 years we can lobby for changes in policy. And Dr. Limpoco has messaged me. Family medicine is really into this, and we can have pilot programs all over. As I've mentioned, Dr. Gia there is a part of the board of family medicine. So she's influential as regards to yung mga CMEs. So Gia, maybe you can, if Gia is still there, sorry hindi ko nakikita, can comment.
Yes, sir. So part of the advocacy yan kasi din yung gap natin in terms of the awareness of this sa mga patients and even siguro sa mga doctors din in the community level. So dalawa yung kailangang i-target natin both sa training and in practice. So sa training naman, we can probably loop this in the programs, in the training programs all over. So currently, we have both the hospital-based kasi and the practice-based. So I think magandang way yon to get a registry talaga of our patients. And then for the CMEs naman, yes, we can also have series of CPD activities. So Dr. Tabu was invited already, I think several times in our conventions and even dun sa mga postgraduate courses kasi we really need to make them aware of this advocacy. I think what is important is for us to have data that would support us in lobbying policy. Kasi yun yung problema. Kasi even in the consulta package, this is not even included. So medyo medyo challenging yun for us, lalo na if we are pushing for the screening of our patients. So medyo mabigat din yon yung mga laboratory tests na yan. But I think if we have the right numbers to show that this is really needed because we have an aging population, then probably it would be easier for us to present this, lobby natin yung mga policies na ito. Yun lang. Thank you.
Yeah, very true. And then si Dr. Obet from UST has a question. Can FFN Philippines be the national administrator for, I think for this, FLS? Can FFN Philippines be the national organization that will collate registries? Actually, yes, Obet, we can do that. Currently, FFN Philippines is connected with the UP, NIH. We are collaborating with UP, NIH, Institute of Aging. I think it's very important that we have an academic support, because this is where we can generate researches and data. And as Gia mentioned, as Elizabeth Armstrong mentioned, as Paul Mitchell mentioned, we need data to support and to lobby for changes. Without data, it's very difficult. I know we know it, but it will not be, kundi hindi papansinin kung walang data. And yes, we will be working on that, Obet. Thank you. And yes.
I have a protocol when I was trained in heart center. It's about doing DEXA for patients. Yes, kasi prone yung mga patients na may cancer, especially they undergo chemotherapy. So pero hindi parang hindi yata na-approve ng IARB doon eh, but parang i-DEXA namin bago mag bone scan yung patient. Maybe I will look into it again kasi parang very crucial yung data for especially for onco patients, no. So I think we should also screen this kind of population. Kaya di ba nagso-supplement sila for while they are undergoing chemotherapy. So parang DEXA plus bone scan, parang ganun. It's more of the nuclear side na research. So there's these are very interesting kasi konti pa lang yung data. So if you're doing, sir, I'm in. I can join you.
Yeah, we can support. In fact, now we have we're planning research in collaboration with cardio, with rehab, di ba? NUCMED is is a potential, no. You have to generate data because these are all data coming from low to middle income countries. It's very seldom produced. Most of the data are from developed countries, and they are also interested, no, into seeing how we generate data, which can be used to support our own clinical standards in the future. We cannot keep on copying kasi the clinical standards of the developed countries. So yeah, that's very important. Thank you. Okay, I think it's 4:30. It's been a very, I think, productive afternoon. I know it's a bit tiring, listening to all of this, but I'm sure, and especially for the students, for the interns and clerks, this is very important, no, as you become true blue doctors, no, in the next few years, no. We are only being sometimes what's being highlighted are the common diseases, but osteoporosis is also a silent disease which can really impact the way we live and the way we age. No, we will all be senior citizens after 20-25 years, and if we will not prepare, no, at this point in time, as Professor Mitchell mentioned, no, we will again be devastated by this epidemiologic emergency, no, of fragility fractures. So it's very important that we start now, and I'm very glad that we all participated in this World Osteoporosis Day activity. No, and I would like to thank, no, again, we will give recognitions to the cardio service and endo service of the Philippine General Hospital, the rehab service, the rehab department, the Department of Family and Community Medicine, anesthesiology. Okay, so I am really grateful, no, and for all the participants from all the hospitals, participating hospitals from the multi-center study, from Vicente Soto, JBL, from POC. No, I hope we can continue this advocacy, no, to push for policy changes. So Vince, can you close the activity? You're there.
Yes, sir. So before we end today's activity, may we call on the following departments, or department representatives and institution representatives for the awarding of the certificates. And may I also call on our executive officer, Dr. Lai, to award our fellow colleagues in the fracture liaison service. So first is the Department of Rehabilitation Medicine, Ma'am Dottie. Then next is the Department of Medicine, Dr. Apaap. Can you represent na lang po? Thank you. And then the Department of Family and Community Medicine. Thank you, ma'am. And then the Department of Anesthesia. Thank you, Dr. Epino and Dr. Salonga for representing. And then also our partner institutions from the north, Jose Biling Memorial General Hospital, represented by Dr. Rene Manalastas, and Veterans Memorial Medical Center. So we'll just give the certificate of appreciation na lang po some other day. So again, thank you and
thank you for our again to our company's partners, no? Amgen Zulig and Montera, makers of Anlin, no, for supporting us for the food and everything. Thank you very much. So see you next year, but we will have continuing program throughout the year. No, we will not just be a World Osteoporosis Day organization or service, no, but we will try to keep all the programs, no, coming, no, and we will involve everybody, no, throughout the entire year. And thank you again for your participation in Happy World Osteoporosis Day. Salamat sa lahat. Thank you.
thank you. May I ask everyone to please come up front for a short photo op.